societies, no?
That is correct. And next thing, physical touch is different than webinars. Physical CME should be there.
So, Shanta, you feel that we should encourage physical and reduce webinars?
No, it is not that. I want to encourage people's participation.
Yes, both.
Exactly. By whatever
conferences, I've noticed. I was in Pune. Only faculties are there. We were somewhere else. Hyderabad also, I saw there were 2 programs which were there last week. Some other societies. That also physical presence of people is very less. That is very sad, you know.
Yeah.
People take so much of effort to make a program. It's not easy. So much of this thing. And I don't know.
But
I think
not only here, so many conferences. Even I was noticing this. I've been seeing this trend the past 1 year. Very sad.
Yeah, only I think last year Ranchi and this year both the Kerala conferences, the attendance was very good.
Yeah,
all the halls were full. Yeah, all the halls were full.
Salem was very good. Then Ranchi was good. Then
Hyderabad presidential conference also was good, ma'am.
No, you forget
Hyderabad
the
was
events.
good. Yeah,
no,
definitely.
Aruna, I'm not telling that. I'm even in medium conferences or small society meetings also. What I'm noticing is less attendance. People and membership also. Membership. I'm really sad seeing that the membership is not at all increasing. Every year, so many thousands of new gynecologists are being added in the system. And membership is not at all moving. That's why I told that Mansukh Mandavia, I should make it mandatory. You have to practice, you have to be a member of the organization.
Post-graduation admission seats also increased tremendously.
Tremendously all over the country. So they all will pass out now. They are becoming fresh consultants. Where are they all going? They are not becoming, then they don't know. And only when they have some problem, some medical legal issue, then they will remember. Then what president is doing, what secretary is doing, they'll be jumping.
It's absolutely correct, Dr. Shanta. It's absolutely correct because people are only using organization when they require. Means if they want to attend some fellowship or medical legal program, or they want to contest election, then and then society
only exactly. That's all.
Or maybe we should give younger members 5 years or so.
Correct, Radha. That's what I'm telling, you know. In my side, it involve the younger people.
Ma'am, we are live now.
Yeah.
Shall I mute everyone else for now?
Yes, you can. Go ahead.
So, am I audible?
Yes, Bhavna. Bhavna, you can start.
Yes, ma'am. A very good evening, respected faculty members. I am Bhavna, and I welcome you all for our Co-Connect live webinar with AMOGS Medical Disorder Committee, Telangana and AP Society, organized by Corona Remedies. Before going ahead with the sessions, I humbly request you all to initiate the session with the lighting of the lamps.
Suryakoti Samaprabha Nirvignam Kurume Deva सर्वकार्येषु सर्वदा.
Thank you. Now, I would like to introduce a very important and prominent member of the society who does not need any introduction. Dr.
Bhavna, you can skip the introduction and go ahead.
Okay, ma'am. I request Dr. Sneha Bhuyer, ma'am, to introduce our faculty members, our chief guests.
Yeah, thank you so much. A very good evening, respected chief guest, Madam Shanta Kumari, President AMOGS, Dr. Rajendra Singh Pardesi, and guest of honor, Dr. Balamba, Madam, and Madam Sujata Dalvi, all the esteemed faculty members, panelists and chairperson, and all the presidents and secretaries of Hyderabad, Warangal, Khammam, and Visakhapatnam societies. A warm welcome to all of you here for this combined webinar of AMOGS Medical Disorders Committee with the Andhra Pradesh and Telangana societies. We're going to discuss very important topics on the medical disorders, especially when the hot discussion is going on about the Anemia Mukt Bharat, and definitely we're going to have lots of speeches and panel discussions on this issue. To start with, I just thank Madam Shanta Kumari for accepting our invitation to be the chief guest, and Madam Balamba and Madam Sujata Dalvi for the guest of honor. Thank you so much, Dr. Pardesi sir, for accepting the invitation, my AMOGS president, and giving us this opportunity. So I would invite Dr. Rajendra Singh Pardesi, who is the AMOGS president and a well-known figure in FOXI and AMOGS as well, for having his precious words and blessings to this webinar. So over to you, Dr. Pardesi sir, for your words.
Madam, invite Dr. Shanta Kumari first.
Yes, yes.
Invite.
No problem.
Yeah, whatever. Yeah.
No problem. Please go ahead.
Madam, please, your precious words from your side.
Let my friend Pardesi.
Yeah, I just thought because being as a protocol, yes. Sir, please, whatever Madam says.
Good evening, everybody. Respected
You
Dr.
can stop
Shanta
share,
Kumari.
Bhavna, stop share. Yeah.
Respected Dr. Shanta Kumari, ma'am. Dr. Sujata Dalvi, Dr. P. Balamba, ma'am. Dr. Sneha Bhuyer, Dr. Aruna Suman, and all. First, I wish to congratulate Dr. Sneha Bhuyer for organizing this webinar with Telangana and AP. Telangana and AP are our sister concern states, and we are associated with them, I think, mostly with Dr. Shanta Kumari. So with this CME on hemoglobinopathies, then thrombophilias and anemia, I think this will be a nice webinar with the galaxy of speakers and chairperson. I think this will be a very interactive and academic webinar. I wish every success to this webinar. I wish every success to Dr. Sneha Bhuyer, our chairperson of Medical Disorder Committee, for her future endeavor in FOXI. I wish every success to Dr. Aruna Suman also for her endeavor in FOXI. Thank you so much for inviting me. Thank you so much.
Thank you so much, sir, for your blessings as always. Thank you so much for your precious words as well. Now I invite the woman of substance who doesn't really need any introduction, who is the first woman, Indian woman treasurer for FIGO, and of course, immediate past president of FOXI. Madam has headed so many organizations, and she's known for her DIRA initiative. So rather than spending much time in her description, I think it's best to listen to her precious words. Madam, over to you, please.
Thank you. Good evening, everyone. It's real nice to see all my people, our own friends, seniors, colleagues, Balamba, Radha, Madam, everyone. And yes, Dr. Pardesi sir is a very senior friend of ours. And Maharashtra has been quite close to us, yes. And AP Telangana are one, okay. So we are all, we may be geographically politically, we're two different states, but we're one state. And we're really looking forward to, we just had a discussion. I think the most important point now is to see that we increase the membership of POXI in our whole country, not only our states, because we need all the gynecologists who are passing out every year to become members of POXI, so that is where there will be under one umbrella, one advocacy, one protocol. And I think that is the best way forward. And very nice to see that people are utilizing this webinar platform. So Sneha and the whole team who is conducting this program, I'm sure that any scientific exchange which is brought to the people's homes, I think that's if it can help them in improving the patient care, I think that's the best service anybody can do. So all the best to all the faculty, and see you all soon in person. Sujata is also there. Hi, Sujata. And so many people. Sorry, I can't mention everyone. All of you are there. So wish you all the best for the program.
Thank you so much, Madam Shanta Kumari. I have worked under your leadership and I know what your capabilities are. Definitely, we make sure that the academics will be our priority. And of course, we focus on the organizational activity as well. Thank you so much. Next, I invite Madam Bhalamba. Bhavna, can we have Madam's CV, please? So, what a short CV Madam has given. Madam, such an illustrious person with a highly decorated CV, but Madam has been very short and sweet. Former HOD Obstetrics and Gynecology Department of Osmania Medical College. And of course, I have witnessed Madam's academics on various platforms. So we would be very happy to have your words of wisdom, Madam. Over to you, Madam Bhalamba.
Thank you, Dr. Sneha. See, the issue is anemia is a very burning topic. If you look at the NH4 and NH5 statistics, instead of anemia Mukt Bharat, we are becoming anemia Bharat. Actually, the numbers are increasing, and we don't know why they are increasing in spite of having the IV FCM products and then, oral products, so many types of iron. And I'm also on the ethics committee of National Institute of Nutrition, where, they are also saying that in spite of the central government program of Anemia Mukt Bharat, only 23% of the school students are utilizing the iron tablets, and out of them only 88% are improving their hemoglobin, in spite of their being very diligently taking the tablets. So I think there is some problem with the oral tablets, and with the recent fatal adverse reactions with FCM, where we have seen even doctors having fatal accidents. I think, we have to do something about this anemia, something about the management and what is going wrong. And today's paper, if you have seen the spurious drugs, so many spurious drugs and so many companies have been shut down by the government of India. 18 pharmaceutical companies have been shut down because they are producing spurious drugs. So these are all problems, I think POXI also has to address this issue also, so that, our women, pregnant women, don't get into problems because of anemia, because we all know anemia contributes to 25% of postpartum hemorrhage and the maternal mortality. So I think this is a very apt subject to discuss. And of late, we are also actually discovering more and more pregnant women with thalassemia minor. So hemoglobinopathies are also very important for us to discuss. And I really am happy that we are discussing these topics today. Thank you. Thank you very much, Dr. Sneha, for having me as a guest.
Thank you so much, Madam, for your precious words. And of course, as you said rightly, that yes, anemia is one of the major causes of maternal mortality, which is actually a direct cause, and the prevalence is so high. So going ahead with this now, I request Madam Sujata Dhalvi, who is the AMOGS secretary and very kind and very helping person. So Madam, over to you for your precious word.
Thank you, Dr. Sneha. At an outset, I would first like to express my gratitude to Dr. Sneha Buyar, who is AMOGS Medical Disorder Chairperson and convener of today's program, for organizing such an excellent webinar along with Telangana and Andhra Pradesh Society on the topics which are very relevant, that is hemoglobinopathies, thrombophilia, and of course a panel discussion on anemia in pregnancy. I would also like to acknowledge presence of our chief guest, Dr. Shanta Kumari, who is the immediate past president of FOXI and currently treasurer of FIGO, Dr. Rajendra Singh Pardesi, who is the president of AMOGS, and of course our guest of honor, Dr. P. Ballama, who is the director of medical education, government of Andhra Pradesh, for their words of wisdom. And I would like to express my best wishes for today's webinar, and best wishes to Dr. Sneha and Aruna Soman for their future endeavor in FOXI. All the best to both of you all. Thank you so much.
Thank you so much, Madam Sujata Dalvi, for your best wishes always. And of course, the opportunity you are providing us for this academic, academically rich programs also. Thank you so much. I would just like to thank once again, Madam Shanta Kumari and Dr. Rajendra Singh Pardesi, sir, for accepting our invitation and gracing the occasion. I would like to thank Madam Balamba and Madam Sujata Dalvi for being the guest of honor for this inaugural function of this program. And I thank all the faculties and panelists and chairperson and all the attendees as well for gracing this program. Thank you so much. And with this, we would like to go ahead with the academic session. And for this, I hand over the platform to Dr. Niharika Allu and Dr. Lakshmi. Over to you, both of you.
Good evening, everyone. And thank you, Shanta, Dr. Sneha, for giving us this opportunity. And I take this opportunity to invite the chairpersons of the first session. Can I have the CVs of the first session, please? Chairpersons of the first session.
Yeah. Bhavna, the chairpersons first.
There need not be elaborate introduction.
Yeah, I think one or two lines, one or two points from you can you can do it from your side, Dr. Lakshmi.
Yeah, Dr. Radha, she has served in very prestigious posts, like she was the immediate past president of OGS Visakhapatnam. She organized the Yuva FOXI South Zone, and she has been the principal of Obstetrics and Gynecological Society, OBG, and Andhra Medical College. And she occupied various positions, and she edited various textbooks and contributed chapters in many of these textbooks. Welcome, Dr. Radha, to this webinar.
Thank you, Lakshmi.
Next slide, please. Our next chairperson is from Warangal, Dr. Madhuchanda, sir. And he is the president of Warangal Obstetrics and Gynecological Society. He has been the professor of Obstetrician in SRC, and he was a retired professor, assistant professor of KMC Warangal. And now he is a consultant at Jivak Hospital. Welcome, Dr. Madhuchanda, sir. And our third chairperson for the first session is none other than our Santa Claus of OGSH, Dr. Aruna Suman. She has served in very prestigious positions, and now she is a professor and vice principal of Jagityala Medical College.
Thank you, Lakshmi.
Welcome, Dr.
Respected
welcome, Dr.
Gynecologist, Dr. Balamba Madam, Dr. Rajendra Singh Pardesi Sir, Dr. Sujata Dalvi Madam, and Dr. Shanta Kumari Madam. Dr. Sneha, thank you for this opportunity. It's a great opportunity to be here in this webinar. Thank you so much.
May I request Dr. Radha to introduce the speaker of the first session, Dr. Niharika Allu, please.
Thank you, Dr. Lakshmi, for nice introduction, and thank you, Dr. Sneha, for involving both Telugu states in this webinar today. And let me introduce our young, dynamic first speaker, Dr. Niharika Allu. She is the Joint Secretary of our society, OGS Vishakhapatnam, and she is the next secretary of our society. So from April onwards, she will be the secretary of OGS Vishakhapatnam. And she is a consultant of OB-GYN by birthright Rainbow Hospital, Vishakhapatnam. She had a brilliant academic profile. She did MBBS from Jipmar, Pondicherry, and then completed post-graduation from Osmania Medical College with flying colors and gold medals. She is associate member of RCOG London, and she contributed a chapter in NNF clinical protocols in perinatology. She is actively involved in FOXI activities locally as well as nationally, and she is a member of Public Awareness Committee of our society also. And she took active part in both our South Zone Yuva FOXI and other, she was a faculty, she's a faculty in other zonal conferences of Yuva FOXI, and also she participated as faculty in ASCOG. I welcome Dr. Niharika to deliver her lecture, and Aruna and Dr. Madhchandar, they want to speak, please.
Yes. Dr. Niharika was my postgraduate at Osmania Medical College. She was brilliant, well-behaved girl who got a gold medal. I congratulate her and I welcome her to speak on this topic.
Thank you, madams. Good evening to everybody. I'll just share my screen. Thank you, Dr. Radha, for that introduction. I bring greetings from the Society of OGSV, Vishakhapatnam, and I thank Dr. Sneha Bhuyar, Chairperson, Medical Disorders Committee, AMOGS, for this opportunity to talk among so many stalwarts and so many old professors. Thank you so much for this opportunity. And I thank Dr. Shanta ma'am for gracing this occasion. So as it's a talk on medical disorders in pregnancy, I think we thought aptly that hemoglobinopathies would be a correct one to do the first session. So today I'll be taking you through two disorders, that is beta thalassemia and sickle cell anemia. And it is a disorders, hemoglobinopathies are something which we don't see very commonly, but definitely when we screen them, we realize that it is actually quite rampant. So just going through the basics, hemoglobin is out of two chains, beta chain and alpha chain. And as you can see, as we grow from fetus to the adulthood, the type of hemoglobin in the blood circulation changes. And we have various hemoglobinopathies based on either a quantitative or a qualitative type of deficiency. So we have sickle cell, which is a single gene disorder. Mutation is occurring at the 6th position, whereas thalassemia is where you have deficiency in beta chains. So I think we have two sectors here. So first one is women who are already known with hemoglobinopathies. And this is the other one where women come to us in asymptomatic person. They come for their booking visits and we have to screen them for hemoglobinopathies. So in my hospital, I screen on a regular basis. And since I've started doing this for quite some time now, I have realized that actually the thalassemia trait and sickle cell trait is actually quite common in the women. We feel sometimes that it is more of some communities which have hemoglobinopathies, but because of intercaste marriages, interreligious marriages, I think the genetics has changed in the population and the traits are quite rampant in all Indian population, and South Asia itself is known for high amount of hemoglobinopathies. So we can do screening in two ways. Either we do a full blood count, and if we see an anemia where the blood indices are abnormal, the blood indices showing microcytosis or hypochromia, and if we do ferritin, and if the ferritin is high, you should suspect a hemoglobinopathy. But even if the ferritin levels are low, it can be because the iron deficiency anemia is masking it. So you should be doing both combined blood picture, and to confirm if when you're suspecting a hemoglobinopathy, you can go ahead and do a hemoglobin electrophoresis, which basically separates the different types of hemoglobin which is present in our body. And depending on that, we get the diagnosis of whether it's a beta thalassemia trait, we have a thalassemia major or a sickle cell trait or a sickle cell anemia. We can also do a HPLC, which is a better method because it is automated, more convenient and faster sample. But if your samplings are more, then HPLC will be more cost effective than hemoglobin electrophoresis. So I urge everyone here today in the audience to do hemoglobin electrophoresis in all your pregnant women at your booking visit, and you'll be surprised to see the amount of traits that you will pick up. So we all know that importance of thalassemia is also because we need to reduce the incidence in the fetus. So it is an autosomal recessive disease. And when we pick up traits, we should test the partner. And if the partner is also having a thalassemia trait, it can have an effect in the baby in 25% of the babies. So here you can see a different combination that is there in a sickle cell anemia. It also has an autosomal recessive inheritance. So as you can see, different combinations can happen. So that is why all pregnant women should have ideally a preconceptional counseling when they are known to have a hemoglobinopathy or if they already have a trait. So genetic counseling is very, very essential. And the first part to do that is to screen the partner for their carrier status. And if we already know about their carrier status and we know that there is definite risk of the baby getting hemoglobinopathy, we can do a prenatal diagnosis by testing for the free cell DNA in the NIPT or a CVS as early as 10 to 11 weeks or by amniocentesis. Or if we know that the risk is very, very high, we could suggest an IVF for ICSI in these patients and ask them to go for a pre-implantation genetic diagnosis. This actually helps in preventing termination of pregnancies once it is confirmed that the baby is affected. So here we can, after PIGD, we can just transfer the healthy embryos into the mother. Also, we can suggest a sperm or oocyte donor depending on the carrier status. And these patients, whenever they're using sperm or oocyte donors, should also be screened for these traits. So why are we worried about thalassemia? We know, but because of thalassemia, we have impaired beta globin synthesis. So the RBCs are abnormal. There is anemia, there is ineffective erythropoiesis. And as a treatment, we give these women multiple blood transfusions. And because of that, there is an iron overload and extravascular hemolysis occurs in the spleen. So when we're looking at beta thalassemia, we have a beta thalassemia major and intermediate. Major is basically where you have a severe anemia and these women require regular blood transfusions. And because of these multiple blood transfusions, they have a progressive iron load, which ultimately needs a chelation therapy. Whereas in intermediate, they are having only a moderate anemia. So why are we discussing this today? We are discussing this today because all these thalassemia children eventually become adults and attain the reproductive age group. And we have novel treatments to treat these thalassemias in the form of stem cell therapy. And I think that is why most of these stem cell storage is actually being used. Most of them suggest that thalassemia is one of those disorders where your baby may need a stem cell transplant. We also have gene therapies where vectors are used to modify the genes to produce normal hemoglobin, or we have genome editing techniques. And splenectomy, even though it is not the ultimate for treatment right now, it is not the first line of choice. It may be needed in some women to do a splenectomy to prevent hepatosplenomegaly. So these women also have low fertility because the pituitary gland has iron overload and that itself can cause hypogonadism. So serum AMH is actually an important biomarker. And in 2011, two separate people had done, Singer and Chang had done studies, and they had found that AMH levels are actually inversely correlated to a serum ferritin. So whenever there is an iron overload, there tends to be impaired ovarian function in these women, and these women may need therapy in the form of ovulation induction with gonadotropins. So these are some studies which were published in 2016, which says that the stem cell transplant after transplantation in these women with thalassemia major, pregnancy outcomes were actually quite good. This study also includes men who have had thalassemia and have been treated, and they have contributed to healthy term pregnancies. But in 2022, we have a study published in Bone Marrow Transplant, which is still pursuing the survival and late effects of these transplantations. So it is yet to be seen whether it is actually a very, very successful model or not, because these women may have some solid tumors also. So this is something which we'll have to wait and see. So let's look at what happens in sickle cell disease. It is also an inherited disease, and it is also quite common in the South Asian community. And with sickle cell, thalassemia can occur in combination and produce a lot of problems. So what is the management of these women? So today I'll be giving you principles of how to manage these women with beta thalassemia and sickle cell anemia. Because of paucity of time, I would just be restricting myself to the basic principles. So firstly, the preconceptional care. It is definitely a multidisciplinary approach where you need a hematologist, a cardiologist, an obstetrician to manage these women. And these women should always be advised to take a folic acid 5 milligram supplementation 3 months prior to planning their pregnancies and continue it throughout their pregnancies. Also, it is very, very essential that these women are assessed for end organ damage, and that end organ damage is reduced before they embark on their pregnancy journeys. So this can be done by aggressive chelation to optimize their iron status, and only when their end organ damage is minimized should they be allowed to have a pregnancy. And also, as I said, the genetic counseling for after testing the partner has to be done to look at the inheritance that these women may have for the babies. Also, because these women have multiple blood transfusions, these women can have a lot of red cell antibodies, and hence having a good blood transfusion unit is very important to process and cross-match blood for these women. And because of these chelating agents, there may be vitamin D deficiency causing osteoporosis, and hence vitamin D supplementation is also very, very essential. Women who have undergone splenectomy in cases of thalassemia or for sickle cell need to be vaccinated to prevent infections. So they need to have Haemophilus influenza and meningococcal vaccine. And every 5 years, they need a pneumococcal vaccine, and penicillin prophylaxis should be given. And if they're allergic, they should be given erythromycin. They should get their annual flu shots. And if they are negative for hepatitis B, they should be vaccinated and also checked for their HCV status. So let's look at what are the end organs which are bound to get damaged in beta thalassemia because of the iron overload. So the first and most important is pancreas. These women can have diabetes because of multifactorial reasons like insulin resistance, iron-induced islet cell insufficiency, autoimmunity, and genetic factors. So since they get multiple blood transfusions, that HbA1c is not a very apt method in these women to find out if they are good for conception or to see how the congenital anomalies may play out. So serum fructosamine is the most important one to be done in these women especially. Also, these women have hypothyroidism. So thyroid status also should be maintained normally. And cardiomyopathies can occur because of iron overload. So ECG, echo, and T2 cardiac MRI should also be done with a target for more than 20, which will indicate that there is only minimal iron in the heart. And if there is a reduced ejection fraction, it is a relative contraindication to pregnancy. So these women should be chelated well. And once the chelation is, the cardiac MRI is good, only then they should be allowed to have a pregnancy. Also, these women can have iron deposition in the liver. So we can do a ferry scan or liver T2. Here, the target should be less than 7 milligram per gram of dry weight. But if it is more than 15, they have not just the problem with liver, they may also have an increased myocardial iron loading. So if they have already become pregnant and we find that these things, when we are doing the end organ damage assessment, we have found that they are high. These women can actually undergo chelation between 20 and 28 weeks. These women also have cholelithiasis and may develop cholecystitis in pregnancy. And as I said, hepatitis C status should be seen because they have a very complex picture during pregnancy and liver cirrhosis. So hepatologist is also very important in a multidisciplinary approach. As I said, osteoporosis can occur because of thalassemia or because of the chelating drugs and hypogonadism. So these women should have their vitamin D supplementation. So how do we do the iron chelation? We have drugs like deferoprone and deferasirox, but these are teratogenic. So these should be discontinued 3 months prior to conception. So that is why it is very important that these women actually have a preconceptional counseling where they are told that these drugs have to be discontinued. And desferrioxamine is safer in pregnancy, but it has a short half-life. It can be used even in ovulation induction, but it is better to avoid it in first trimester because of lack of safety data. And it can be used safely after 20 weeks if needed. If we feel that there is end organ damage, we can use them even during pregnancy. So how do we care for these antenatal women? They need just the regular antenatal visits, but because there is a high chance of FGR because of the chronic placental insufficiency, these women should be followed up every 4 weekly after 24 weeks to pick up on this FGR. Also, serum fructosamine should be done on a monthly basis, and thyroid status should be maintained. And as I said, if we see cardiac decompensation, chelation should be done. These women should be given oral iron only if their serum ferritin is low. There is no role for parenteral iron in these women. They need regular blood transfusions, and they should also have a detection of their red cell antibodies because they've had multiple blood transfusions. So they may have got different antibodies. So at booking and again at term, they should be screened for these so that if they have any abnormal antibodies, the cross-matching team should be accordingly intimated. Also, these women, especially the ones who have had splenectomy or women who've had high platelet counts, should be started on low dose aspirin, and thromboprophylaxis should be given in all antenatal admissions. And if a woman has had splenectomy and also has a platelet count more than 6 lakhs. So how do we transfuse these women? So if there is beta thalassemia major, they need regular blood transfusion. So our aim is to maintain the pre-transfusion hemoglobin at 10. You give every 2 to 3 weeks, you monitor the hemoglobin and transfuse either a 2 or 3 unit transfusion. And in case the raise is less than 12 grams after 1 week, you can give a top-up transfusion. Similarly, in intermedia, the transfusion should happen only if there is a worsening of anemia or if you suspect an FGR. In intrapartum care, these women, as I said, we should have a cross-matched blood ready. The blood transfusion team the blood bank should know about the red cell antibodies, if any. And because these women have a high chance of FGR, these women should have a continuous intrapartum fetal monitoring. Even though they have some skeletal disformities, C-section is not the only choice of delivery, and it should be done only for obstetric indications. And in beta thalassemia major, because these women have transfusions and we do not give chelation during pregnancy, there is a high concentration of non-transparent bound iron, which can cause a free radical change and even cardiac arrhythmias during stress of labor. So that is why peripartum chelation therapy is recommended, where IV desferoxamine is given during labor. Also, in the postpartum period, these women are prone for a thromboembolism. So prophylactically, low molecular weight heparin should be given for 7 days following a normal delivery and up to 6 weeks in a C-section, and breastfeeding should be encouraged. Coming to a sickle cell anemia, here you can have in pregnancy various types of sickle crisis, and maternal risks are increased because of these crises which are precipitated because of various conditions in the mother. They can also have acute chest syndrome, thromboembolic events, exacerbation of anemia, and an increased risk of infections like UTI. They are prone for preeclampsia and eclampsia, and they may also already have some chronic diseases like pulmonary hypertension, sickle nephropathy, and proliferative retinopathy. And obviously iron overload, just like in thalassemia patients. So the fetus can, similar to thalassemia patient, can have an FGR. They may have a preterm, also a fetal distress because of hypoxia, and they may need induction and a C-section. And because of these red cell antibodies, we may also need to have a lookout for hemolytic disease in the newborn. So similar to thalassemia, these patients also need a folic acid supplementation. And since these women may already be hypertensive because of some nephropathy, they need to stop these AC inhibitors or ARBs if they are already on them. And hydroxyurea is also a very good drug which is used for sickle cell patients to reduce their acute painful crisis and acute chest syndrome. It also decreases their need for blood transfusions, but it also happens to be a pregnancy category D drug. So it should be stopped just like other chelating agents 3 months prior to conception. But in case the patient is already conceived, we could just do a level 3 ultrasound to look for any structural anomalies. We do not need to terminate just basis on that. And we should always screen these women again for any end organ damage like retinopathy and renal and liver dysfunction and pulmonary hypertension. This should be done annually. And if it is not being done annually, they should be done for the first time during pregnancy. So we screen for all these infections, do a urine examination and blood pressure checkup at each antenatal visit, and a midstream urine culture monthly because they are prone for infections. And transfusion should be given in a sickle cell patient only if it is severe anemia, and exchange transfusion can be done in stroke or acute chest syndrome. So in sickle cell anemia, especially, we should avoid any precipitating factors for a crisis like dehydration, which can happen because of persistent vomiting. We should avoid exposure to extreme temperatures, overexertion, hypoxia, and stress. These women are prone to preeclampsia. So we should start low dose aspirin in these women, and they also have a chance for going into thromboembolic events. So antenatal admissions, low molecular heparin should be given. And NSAID should be used only up to the age of, up to the gestation of 28 weeks to manage any crisis pain. So these women should be delivered in a tertiary care center and electively delivered by 38 to 40 weeks. And C-section again, only if there is an obstetric indication or if you're anticipating some complications. Definite pain relief should be given in these women, and these women should be kept warm during labor and avoid dehydrating these women. Continue to monitor the fetus electronically, so to pick up any fetal distress, which is quite common in these women, and cross-match blood and actively manage the third stage. In the postpartum period, these women need early mobilization to prevent venous thrombosis, and they should be hydrated and oxygenated well. Breastfeeding should be encouraged. And as in thalassemia, they should be given a prophylaxis with low molecular weight heparin up to 7 weeks after a normal and up to 6 weeks after a C-section. And newborn should be screened for a sickle hemoglobin. So my talk will not be complete without talking about contraception, because as I just told you in all my slides, the preconceptional counseling is very important to stop these drugs which are teratogenic and also manage their end organ damage. So contraception is a very essential part of a thalassemia or a sickle cell. So these can be these women can be advised barrier contraception. They can be given POPs. DMPA, again, they already have osteoporosis, so you may have to consider them. LNG IUS is a good option. Combined OC pills again should be a second line because of the chances of VTE. Copper T again can be placed, but if there is any source of infection, especially in sickle cell, we should have a rethink. And implants are also coming into India, so they also can be offered to these women. So my take home would be to screen all your patients for hemoglobinopathies, even if they are asymptomatic, irrespective of the geography. And once you have picked up on a trait, do a prenatal diagnosis and counsel these women for the risk of inheritance to their fetus, and avoid teratogenic drugs. Never forget to ask for drug history, assess their end organ damage, take help of hepatologists, hematologists and cardiologists to manage these patients. Have a transfusion regimen that is taken up in as a protocol in your unit and your blood transfusion units, and prevent preeclampsia and thromboembolic events. Thank you so much for your patient hearing.
Congratulations, Niharika. That was a very comprehensive, conceptual, and clear presentation of a complicated topic. And as you said, identification of pregnant women with hemoglobinopathies, and also identification by prenatal screening of the fetus are the hallmarks of this hemoglobinopathies, because we otherwise will miss actual incidence of prevalence of these hemoglobinopathies in our country, especially as a Southeast Asian country, where the incidence is definitely more than what we expected. And the other thing is, I want to, one thing I disagree is the IUCD. I always say the IUCD infections are insertion related. IUCD as such will not cause any infection, because this is a long-acting reversible contraceptive.
Exactly.
IUCD is almost they
very good
have any contraindications in majority of medical disorders. And the other thing is, how do you counsel these partner, the couple, for termination? Suppose the prenatal screening identifies some hemoglobinopathy in the offspring. How do you counsel them?
Only if we confirm, that the actual baby is affected. So we have to either do a confirmatory test like a CVS or an amniocentesis, and we have to confirm that the baby actually has the problem. Only then we can advise them for termination. Just because risk is there, we will not go ahead with the termination.
I know
that we are not hematologists.
I know we are not hematologists, but what do you think? What do you mean by affected fetus? Can you just go into that? Because the carrier
molecular analysis DNA testing can be done for the baby, but generally sickle cell is easier to pick up, but beta thalassemia sometimes takes longer to come, like after 2 years, especially the smaller ones, intermedia and minor, they may take a little longer for us to pick it up actually.
Yes, though we are obstetricians, we should also be very well versed in these medical disorders. Otherwise, counseling of the couple will be very difficult.
Yes, ma'am.
Thank you.
Thank you, ma'am.
I would just make one comment here, Dr. Niharika, wonderful presentation. I think you have whatever precautions also you have enlisted. Only one suggestion, yes, pre-marital counseling and preconception counseling definitely plays a role here. And if you find a woman with trait, yes, you have to test her partner as well, so that we are also ready, and we are ready to answer her queries. What is the percentage of the affected as well as the trait? So and of course what you talked rightly, CVS, the Korean virus sampling, I would say a chordocentesis and direct testing of for the hemoglobinopathy. That is what we are doing it here routinely. Thank you so much.
I also add one more thing. Yeah, when you want to screen them, because not everybody can afford to go in for a screening
HPLC. Yes,
HPLC. So what you can do is get a hemogram done.
Yes,
if the RDW, if red cell this thing is uniform, you have to suspect thalassemia.
Yes.
If it is different, it is microcytic hypochromic iron deficiency anemia. But when it is uniform, you know that it is thalassemia, because in thalassemia, the red cells will be uniform microcytes.
Yes. Very well said, madam. That in fact I have added in my panel discussion slide. Thank you so much. We can move ahead, I think.
Thank you, ma'am.
Okay, thank you very much, Dr. Niharika, for such a wonderful presentation. And I thank all of my chairpersons, Dr. Radha, Dr. Murli Chandar sir, and Dr. Aruna Suman for being our chairpersons and making the interaction very lively. Niharika, can I ask you to take over for the next session, please?
Thank you. Thank you, Dr. Lakshmi. So with this, we move on to the next session. So I would like to introduce the chairpersons for this session, Dr. Bodipudi Sailaja. She is the Director and Clinical Head, Department of OB-GYN at Shyamala Hospitals, Khammam. And she is also Fellow of Indian College of Obstetrics and Gynecology and has been a past president of Khammam OBG Society. She's conducted Telangana State Conference in 2016. Welcome, ma'am. Welcome, Dr. Shailaja. Now we have Dr. A. Shyamala, who's the Vice President of our society, Obstetric Gynec Society of Visakhapatnam. She's presently an Associate Professor of GVP Medical College, and she was the Organizing Secretary for Yuva Foxy South Zone in 2020 and Organizing Joint Secretary APCOG in 2002 and 11. And she's also a very active member of our society and always a guiding force for all of us. Welcome, Dr. Shyamala. May I now request Dr. Shailaja to introduce the speaker, Dr. Sandhya Rani.
Yeah, a very good evening to all. Respected chief guests of today webinar, Dr. Shantakumari Garu, Dr. Rajendra Singh, Dr. Sujata ma'am, and respected seniors and my dear colleagues, a very good evening. Thank you for making me a part of this webinar, academic session, and I congratulate Dr. Sneha and the team for this wonderful session. Before starting this, I myself have a small doubt, Dr. Niharika. Do you want us to, to screen for all the women or only women with anemia, that is HB less than 9 grams or so?
If we have an affordable clientele, we could screen them for like directly do a hemoglobin electrophoresis. But as I said, you could do a 2-step also. You can just do a routine hemogram. And if your blood indices are coming as microcytosis, then you can go ahead and, when you're suspecting, then you can go ahead and do an electrophoresis. But
Yeah,
ideally, screening regularly would be better. But again, if it's not cost effective, probably not.
Okay. Here, because we have a belt, Bhadrachalam, where the thalassemia is very common.
Yes.
So for those people, generally we do on regular basis.
But now I think the geography is not very, like, we cannot really demarcate anymore. I see a lot of combination, like especially marriages are having a lot of like intercaste, interreligious marriages is happening. So we don't really know if the geography is restricted anymore.
Okay, thank you for that nice presentation.
Thank you.
Now coming to our topic today. Today our topic is now Dr. Sandhya is going to speak on thrombophilias. Dr. Sandhya is the senior consultant in gynecology OBG. She's the director and the chief consultant Lakshmi Narasimha Hospital and Ekashila Hospital, Hanamukunda. She's an active member of Warangal OBG Society and also Foxy. I request Dr. Sandhya to start her topic.
Thank you. Thank you, Dr. Shyamala, for your kind introduction.
Shailaja.
Dr. Shailaja.
It's okay, ma'am.
Okay. Respected seniors, Dr. Balamba Madam, Dr. Shantakumari Madam, and Dr. Sneha Ma'am, and other chairpersons, speakers, panelists, faculty, friends, colleagues, very good evening to all. I would like to thank Dr. Sneha Madam for giving me this opportunity. Today, my topic of discussion is thrombophilia during pregnancy. In this, we are going to discuss about overview and introduction, incidents, what are the risk factors, how to classify, how to grade thrombophilias, and types of thrombophilias, how to screen, clinical evaluation and approach to thrombophilia, and what are the complications, how to prevent, how to manage, and case-based scenarios. Inherited acquired deficiencies of inhibitory proteins of coagulation cascade are collectively referred to as thrombophilia. The word philia means affinity to thrombus. The word, when we see thrombosis patient, the common questions about thrombophilia are, who should be tested? So we test all the patients, or there are some subset of patients. And another question is when to test, like either during acute event or after completion of anticoagulant treatment. The third question, why test? Because these tests are costly, is going to change our management or is going to change outcomes. So next question, what to test? There are panel of tests. Should we test all these in every patient, or not only where indicated, and then how to treat and how long to treat. And this is a like a balanced coagulation system. In this, the procoagulant and anticoagulants. So,
Madam, sorry to interrupt. I think your slides are not moving, madam. Are they moving?
Yes, not moving.
Yeah, so I think for everybody, you can check. Can you just click on the slide and then go ahead, madam?
Now?
Click on the slide, madam.
Yes, ma'am, now?
No. Can you all see this?
Ma'am, can you once stop share and then again share?
Make it on slideshow first, full screen, and then you try and move the slides. Slideshow, please.
Madam, now
no, it's not moving.
Yeah, it is not moving. You have this slideshow icon on right side, if you can see, of your screen. Just beneath your slide, there is a slideshow icon. So please click on that first. Now I can see that it's moving, but just make it full screen here.
Now, madam, able to see?
Yeah, I could see one slide change, but you can just try and change one or two slides so that there will be no interruption. Sorry. Thank you.
Ma'am, you can stop slide share once and then again share the slides.
Yes. Sorry.
Yeah. Now they are moving. Madam, you can take it to the initial slides. Just take it up back.
Yes.
Yeah.
Yes. And this is coagulation system. This is a balanced procoagulants and anticoagulants which keep the blood in the fluid state.
Madam, I request you to take it to the first slide, first 2-3 slides. It's already 27, the slide number is.
No, ma'am. Now, this is the first slide only, ma'am.
Is it a problem with me only, Dr. Sailaja, or you all can see the first slide?
No. This is not the first slide. Sandhya,
Yeah.
ma'am, to go back, child. Pregnancy complications is the slide which we are seeing. Now
Yes, now.
Now you start.
Now it's
Perfect.
next slide, madam.
Yes,
Next
madam.
slide.
Yes, correct,
Yes,
correct.
perfect. Go ahead.
Yes, ma'am. Thank you. And coagulation system is balanced with procoagulants and anticoagulants, which keep the blood in the fluid state in the normal condition. And during an injury, the procoagulants are activated to cease the bleeding. And in this is the intrinsic and extrinsic pathway. In this, the factor 10A, which is like prothrombin, leads to thrombin formation, and which in turn, with the help of fibrinogen, the release of fibrin, it will leads to stable fibrin clot. And the inherited thrombophilias and their effect on coagulation cascade. The prothrombin is the very important component. Where the prothrombin leads to increased thrombin, it leads to it maintained by coagulation. But in inherited thrombophilias, where antithrombin deficiency and inherited thrombin levels will be decreased, and in protein S deficiency and protein C, there will be with the protein S, inactivated factor 5A and inactivated factor 8A, which in turn controls thrombin generation, which causes increased prothrombin levels, leads to increase in thrombin and clot formation. And we all know the varicose triad. In this, the stasis, vessel wall injury, hypercoagulability leads to thrombosis. And coming to incidence, the inherited thrombophilia is 15 to 20%. The enhanced thrombogenic potential during pregnancy causes 50 to 80% of all maternal thromboembolic events. The incidence of VTE is 1 in 500 to 2000 pregnancies. The thrombophilia is the biggest risk for VTE. Women with inherited thrombophilias, previous history of first degree relative with history of thrombosis, 15% of women with VTE will have a pulmonary embolism. 10 to 15% of women having a pulmonary embolism will die. So the pulmonary embolism is the most common cause of pregnancy related death. And the classification of thrombophilias, they're classified into inherited and acquired. Coming to inherited thrombophilias, again, there are high risk abnormalities, low risk thrombophilias. So the defects of anticoagulant pathway like antithrombin 3 deficiency, protein C, protein S, and factor V Leiden homozygous, compound heterozygous comes under high risk thrombophilias, and factor V Leiden heterozygous prothrombin gene mutation comes under low risk. And prothrombin 2 gene mutation is increased levels of procoagulants. And coming to acquired thrombophilias, antiphospholipid syndrome comes under acquired thrombophilia. And how to risk categorization? So is high risk, intermediate risk, low risk. Homozygous factor V and antithrombin deficiency comes under high risk. Protein C and protein S intermediate risk. Heterozygous factor V, heterozygous prothrombin comes under low risk. And the other risk factors like obstetric risk factors and general factors which increase thrombosis, thrombophilia, like cesarean delivery, cesarean hysterectomy, diabetes mellitus, hemorrhages and anemia, hyperemesis gravidarum, and prolonged bed rest, and twins, multifetal gestation, multiparity, preeclampsia, and stillbirth. Other general risk factors: age more than 35 years, smoking, surgery, previous history of surgery, previous history of any antiphospholipid antibodies, and history of connective tissue disorders, dehydration, malignancy, nephrotic syndrome, and high BMI, hormonal contraceptives, sickle cell disease, prior VTE, inflammatory bowel diseases. These are all risk factors for thrombophilia. Why is pregnancy and postpartum at increased risk of VTE? So generally, normally, the hemostatic changes in pregnancy, the anticoagulants and procoagulants. The anticoagulants will decrease, like protein S will be decreased, activated protein C is decreased, plasminogen activator decreased, and other procoagulants increased, like prothrombin, factor V, 7, 8, 9, 10, and fibrinogen also increased, D-dimer is increased. And why the hypercoagulable state during pregnancy? It promotes clot formation, extension, stability, and stasis, like in large veins of lower extremities because of uterine compression, and there will be vasodilatation and decreased mobility. And coming to inherited thrombophilias, like factor V Leiden mutation, it accounts for 40 to 50%. It is autosomal dominant and incomplete penetrance characterized by relative resistance to active C protein, leading to inability of the protein C, already discussed. And factor V Leiden, the blood clot formation, like in brain, lungs, liver, and the humoral vein and popliteal vein are the common sites. Factor 2 prothrombin gene mutation. This, like factor 2 increases prothrombin, leading to greater thrombin generation, and this in turn leads to prothrombotic state. And protein C deficiency, the deficiency can be a result of multiple different genetic mutations leading to varying degrees of hypercoagulability. And protein S, since the protein C anticoagulant activity is dependent on protein S, the deficiency of protein S is associated with hypercoagulability. And the prevalence of antithrombin deficiency is 1 in 500 to 5,000. Antithrombin inactivates thrombin and factor 10A, therefore its deficiency promotes coagulation. And effects of thrombophilia in pregnancy. So the thrombophilia, it can cause early pregnancy loss, recurrent first trimester loss, second and third trimester pregnancy loss, stillbirth, preeclampsia, placental abruption, FGR, HELP syndrome. Thrombophilia and complications in pregnancy, like, and other pregnancy complications: venous thrombosis, pulmonary embolism, stroke, and recurrent second trimester abortions. The overall of inherited thrombophilias and advanced pregnancy is modest. This suggests that their effect is likely to be contributory rather than primary cause. And the recent studies have shown weak association between hypertensive disorders of pregnancy, abruption, and acquired thrombophilias. And coming to association between inheritable thrombophilia and adverse pregnancy outcomes. In this, the factor V Leiden and prothrombin gene mutation, it will cause a lot of side effects like VTE, early pregnancy loss, recurrent first trimester, second trimester loss, and late pregnancy loss, preeclampsia, placental abruption. But compared to protein C, S, antithrombin hyperhomocystinemia, only the incidence is increased VTE, not other effects. And screening. Whom to test, what to test, why to test, when to test, how to treat, how long to treat. So in whom to test? In women who are planning pregnancy with previous history of unprovoked VTE, history of recurrent VTE, asymptomatic individuals like with family history, strong history of thrombophilias in the family, antithrombin 3 deficiency, protein C, S, homozygous 5 factor mutation, homozygous prothrombin gene mutation, and compound heterozygous gene mutation. And who not to test? In women with previous adverse pregnancy outcomes, all the guidelines, ACOG and British guidelines, the ACOG recommends against testing, and British guidelines, British Society recommends against testing, but RCOG recommends testing for inheritable thrombophilia for recurrent pregnancy loss. However, recent TOG of 2022 and ASRM and ESHRE recommends against testing. So what tests to be done? For inherited thrombophilias, the factor V Leiden and prothrombin gene mutations are very common. In these are genetic disorders, so we have to test only for genetic testing. But in antithrombin and protein C, protein S deficiency, only functional assay should be done. So what are the goals? Goals of testing: to aid decision making for future thromboprophylaxis, to guide testing of family members regarding risk association with contraceptive pills and pregnancy, and how to prevent. From obstetrician point of view, it is necessary to know whom to give thromboprophylaxis, what agent to use, when it should be started, and for how long it should be continued. So various guidelines, RCOG and ACOG, all recommended documented assessment of there is a risk score, the factors for VTE in early pregnancy or before pregnancy. So this VTE score, it will be available in online website. There is a risk assessment score for this. Based on this risk, whether the risk assessment score, if the total score is more than 4, so the antenatally consider thromboprophylaxis from the first trimester. If the total score is 3, antenatally consider thromboprophylaxis from 28 weeks onwards. If the total score more or less than 2, postnatally consider thromboprophylaxis for 10 days only. So if prolonged admission more than 3 days or readmission within the puerperium, consider thromboprophylaxis. So treatment of thromboprophylaxis, the non-pharmacological agents like early ambulation, anti-embolic stockings, intermittent pneumotic stockings, proper hydration, and cough exercises. And drugs for thromboprophylaxis, low molecular weight heparin, unfractionated heparin, and newer drugs like heparinoids, factor 10A inhibitors, and direct thrombin inhibitors like lipiridine, hiruridine, and biovanillin. And coming to unfractionated heparin, it's a safe to use in pregnancy, does not cross placenta, lacks fetal toxicity, and for prophylaxis, heparin dose dependent on weight and APT2 value. For prophylactic dose, it should be subcutaneous. For weight in between 50 to 90 kgs, 5,000 units for in first trimester, and from 14 weeks onwards, 7,005 units 2 times. At 28 weeks, 1,000 units, 10,000 units 2 times, and the target APTT to achieve is 2 to 2.5 times the INR value. And unfractionated heparin in acute cases of DVT, the loading dose is 80 units per kg, followed by 18 units per kg. The target maintained dose is 1.5 to 2.5 times the control. And the APTT should be monitored 4 to 6 after loading dose and 6 hours after changing the dose, and daily once the target level is achieved, and once IV dose continued for 5 to 7 days, then convert to subcutaneous dose. And what complication will expect? Like bleeding, skin necrosis, thrombocytopenia, and osteoporosis. And the complications are heparin-induced thrombocytopenia. It can be early onset, late onset. The early onset within first 48 hours, late onset 5 to 14 days of therapy. The antidote is protamine sulfate. 1 milligrams of protamine sulfate neutralizes 100 units of unfractionated heparin. And low molecular weight heparin is the drug of choice for thromboprophylaxis, safe in pregnancy. Effectiveness of low molecular weight heparin assessment should be measuring anti-10A levels, and for prophylaxis, enoxaparin 40 milligrams daily. In high-risk therapeutic dose, enoxaparin 1 milligram per kg twice daily to be given. And contraindications to heparin are antepartum hemorrhage, PPH, stroke in last 4 weeks, and thrombocytopenia, uncontrolled hypertension like 200 by 120, and severe renal and hepatic diseases. The heparin should be stopped before elective cesarean, and unfractionated heparin should stop at least 12 hours prior to surgery. And in epidural or regional analgesia, the prophylactic low molecular weight heparin should be stopped 12 hours prior to the surgery. The therapeutic dose should be stopped 24 hours prior to the surgery. So the anticoagulants should be started in postpartum period after 4 to 6 hours in normal vaginal delivery and 6 hours after cesarean section. And during pregnancy and 6 weeks after postpartum. So previous history of unprovoked VTE, high risk thrombophilias with no VTE, family history of unprovoked or estrogen provoked plus 3 other risk factors, the low risk thrombophilias plus 3 other risk factors. We have to give thromboprophylaxis during pregnancy and 6 weeks after delivery. And thromboprophylaxis from 28 weeks. The family history of unprovoked or estrogen provoked plus 2 other risk factors, low risk thrombophilias plus 2 other risk factors. And during pregnancy and postpartum, according to ACOG recommendation, previous history of VTE with high risk or low thrombophilias, no history of VTE or positive for high risk thrombophilias, no history of VTE plus positive for low risk thrombophilias plus family history, and compound heterozygous abnormal. And coming to acquired thrombophilias are APLA syndrome. The antiphospholipid antibody is defined, syndrome is defined by persistent presence of antiphospholipid antibodies in patients with recurrent venous or arterial thromboembolism or pregnancy morbidity. It can be primary APLA, secondary antiphospholipid syndrome. Primary is due to idiopathic, secondary SLE infection, drug reaction, and lymphoma. Antiphospholipids reduce HCG release and inhibit trophoblast invasion, which may explain miscarriage in them. And there is a classification of antiphospholipid syndrome. It's a Sapero classification. Criteria to say definite antiphospholipid syndrome is present if at least one of the clinical criteria and one of the laboratory criteria are met. And pregnancy complications with the antiphospholipid syndrome, fetal complications, it causes recurrent pregnancy loss, FGR, premature birth, fetal distress, NICU admissions, and maternal complications, preeclampsia, HELP, VTE, and abruption. And no previous history of VTE, low dose aspirin plus low molecular weight heparin prophylaxis, the pregnancy and postpartum 6 weeks. The previous history of VTE, oral anticoagulation changed to low molecular weight heparin and low dose aspirin during pregnancy. And postpartum requires bridging to oral anticoagulants as they are on anticoagulants indefinitely. And differential diagnosis, DIC, heparin-induced thrombocytopenia, thrombotic microangiopathies, sepsis, vasculitis, preeclampsia, and HELP syndrome. And coming to case scenarios, in case 1, 32 years old, Gravida 3, Para 1, Live 1, Abortion 1, came for counseling at positive pregnancy home test. And obstetric history is first pregnancy 5 years ago. The cause was uncomplicated term normal vaginal delivery. Second pregnancy 3 years ago, spontaneous miscarriage at 12 weeks. Past history, she's type 2 diabetes and diet and exercise, no chronic illness. Family history, father had lung cancer, mother has a diabetic and history of DVT occurred after long flight journey. And patient says that her mother has genetic disorder, which causes her to get clots. So on early pregnancy scan corresponding to 6 weeks of gestation. So in this, whether to screen for thrombophilia or not, whether to treat or not, because considering the risk factor, abortion at 12 weeks, mother having genetic disorder and DVT, any patient who has a first degree relative with thrombophilia is recommended to screen and treat for thrombophilia. Coming to case 2, in this, the 26 years old Gravida 4 paravan abortions 2 comes in her first prenatal visit, 8 weeks of gestation. The first pregnancy spontaneous abortion and history of DNC done, and second pregnancy at 29 weeks, she developed right lower extremity DVT, followed by unexplained fetal demise at 30 weeks, and labor was induced with prostaglandin E2. The fetus is normal without any congenital anomalies. Autopsy was unremarkable. And third pregnancy, again spontaneous first trimester loss. Her sister has a history of recurrent DVT. So in this also, whether to screen for thrombophilia or not, whether to treat or not. So definitely we have to screen and start low molecular weight heparin even in first urine test positive. Sometimes even before fetal cardiac activity also we can start low molecular weight heparin. And third case, 25 years old unmarried, started on OCP for irregular cycles, no comorbidities, no surgical history, no family history of VTE, but develops DVT of left lower limb, and whether to test for thrombophilia or not. Because in this, it is a provoked VTE. So unprovoked VTE, in this, the test is not recommended. In only provoked VTE, pregnancy, estrogen, HRT and contraception, surgery within 3 months, leg trauma or fractures, more than 1 week bed rest due to illness, travel lasting more than 6 hours, active malignancy, you have to test. In this, no need to test. And oral contraceptive pills is a provoking factor. Hence, such patients do not require thrombophilia testing. And last case, 20 years old college student presented with unprovoked DVT, no medical or surgical history, family history of VT in mother and brother at young age. So what next? To test or not test for thrombophilia? When to test? The recommendations are to test or not test for thrombophilia. They require testing for inherited thrombophilia and not for antiphospholipid syndrome, and should not be tested at the time of acute VTE while on anticoagulants and pregnancy and immediate postpartum. And coming to summary, pregnancy increases the overall risk of VTE by 4-fold. Various conditions developing in pregnancy such as preeclampsia and obstetric hemorrhage further increases the risk of venous embolism. Risk factors for VTE could be pre-existing or transient or newly developing. It is important to identify and thus classify patients into risk groups depending on the type and number of risk factors. And low molecular weight heparin is the drug of choice for thromboprophylaxis. Aspirin is not recommended for thromboprophylaxis in pregnancy. Dose and duration of heparin therapy should be individualized depending on the risk group. Management of VT in pregnancy needs collaborative effort of obstetrician and hematologist. Thus, with a high index of suspicion, thorough assessment and proper anticoagulation, the morbidity and mortality due to VT in pregnancy can be reduced significantly. So, take home message: pregnancy is a hypercoagulable state. Inherited and acquired thrombophilias further raise the risk of maternal VT. Fetal adverse outcomes are not likely aside from pregnancy loss. The high-risk thrombophilias include factor V Leiden mutation, homozygous prothrombin gene mutation, homozygous antithrombin deficiency, and antiphospholipid syndrome. And women with a history of idiopathic DVT and those with a family history of thrombophilia should be screened, and the high-risk thrombophilias are managed with low molecular weight heparin during pregnancy. Thank you.
Thank you, Dr. Sandhya, for such a wonderful presentation. May I ask Dr. Shyamla to give her remarks?
Yeah. Dr. Sanjay, it's a very comprehensive coverage of a very complicated topic. I take this opportunity to thank Dr. Sneha Buyar, Chairperson, Medical Disorders Committee, for making me part of this academic session. I thank the chief guest also for being with us. Dr. Sanja, I have a small doubt. When we take the percentage of inherited thrombophilias, those are not forming a major part.
Yes.
Like suppose we are sometimes caught aware with a patient which may be who may be having a suspicion of thrombosis. Then how would you like us to proceed in such situation? See, if we have a history and if we have any predisposing factors, yeah, we will be definitely taking this screening test.
Yes.
How to suspect, and when we have a suspicion, what test do you suggest?
With the history of VTE, non-recurrent, like VTE with high-grade thrombophilias, first degree relative, definitely we have to undergo test, madam.
Yeah, that's very good. Suppose if we are seeing a clinical situation, how to, what are the tests to proceed? See, the woman is not having any previous history of thrombosis, and she came to the antenatal with leg swelling or something. So what tests are suggested? Do you suggest
Clinical examination? By examination of the patient, is there any pain, swelling, or any superficial thrombophlebitis, or any signs and symptoms? And then we advise ultrasound, Doppler studies of the limb, and also other investigations like protein. Commonest thrombophilias are protein C and protein S. So we'll advise the genetic testing.
Yeah, D-dimer, will it be very significant?
Yes, normally even pregnancy, the D-dimers are also increasing, no, madam. So
yeah, the negative
not that much significant.
Has a negative predictive value. Nowadays, when we have a suspicion, we have compression ultrasound also, because that may demonstrate the presence of where there is a suspicion and all that. And see, you gave me, like in the case scenario, risk score. When you spoke about the risk score too, what is your suggested treatment modality for risk score? And how is it differing from risk score 3? That I could not get.
They have given a risk score, madam. That
4, 3, 2, and 1 you gave.
Yes, madam.
What is the management differences in risk score 3 and 2?
And there are already existing factors, whether obstetric factors, non-obstetric factors, or newly appeared factors. Based on that, there is a score 4, 3, 2. If the score 4 or more, the current risk factor should be considered for prophylactic low-dose molecular weight heparin throughout antenatal period, will require, and even 6 weeks postnatally also. And for score 3, the risk factors should be considered for prophylactic low molecular weight heparin for from 28 weeks. 28 weeks onwards.
Yes. And 2?
And any woman with current factors 2 should be treated with low molecular weight heparin postnatally, not during pregnancy. Not during pregnancy. Postnatally for 10 days.
And what is your take on thromboprophylaxis in valve replacement? Woman with a valve replacement.
Valve replacement, already they are an anti-warfarin. So when they are planning for pregnancy, they have to consult again. They have to switch down to low molecular weight heparin. Then first trimester we have to give low molecular weight heparin to prevent embryopathy, warfarin embryopathy. And then if the patient is affordable, we can continue. Or if the patient is not affordable, we can switch over to warfarin in second trimester.
Okay then.
And again at 36 weeks,
at 36 weeks, yeah, before time of delivery, switch over to LMH.
Yeah, or unfractionated heparin.
Or unfractionated. Thank you, Dr. Sanjay.
Thank you, ma'am. Thank you, Dr. Sneha, ma'am.
It was a wonderful presentation, very clear. I think complicated topic made quite clarified. So thank you so much.
I have a doubt, ma'am.
Yes,
suppose if the patient has already 2 or 3 recurrent pregnancy losses, and again if she comes with 2 months pregnancy, if we are suspecting, then what are the tests to be done at that time?
I think recurrent pregnancy loss should be a separate program itself. But yes, as you have said that yes, one abortion can be it can be there anywhere 15% almost the incidence. But second abortion, consecutive spontaneous abortion, definitely needs to be tested, and it has to be tested in all angles. But yes, thrombophilia. And again, you have obesity, thyroid dysfunctions, all these tests. In addition, definitely karyotype, husband and wife, the parental karyotype also. So we need to go for, I think, a very elaborate discussion on this. But definitely to consecutive abortion, we have to subject this woman for further investigation. And yes, thrombophilia can be one of the investigations. Yeah.
During pregnancy, so it can be done. Yeah.
Yes. As Niharika has said, for hemoglobinopathies, this is also true because I'm practicing here since last 30 years as high-risk obstetric practitioners. So many patients of hereditary thrombophilia we are finding nowadays, and we are managing well with low molecular weight heparin and aspirin as combination. Thank you.
Thank you, chairpersons. Thank you, Dr. Sandhya, for such a wonderful presentation. With that, I think we'll move on to session 3, which is a panel on anemia in pregnancy. And it is my pleasure to be introducing the moderator and the expert for the panel discussion.
So Bhavna, you can project the first slide. Bhavna, you can project my side. I think continue with the presentation. Yeah.
So I think we all know who Dr. Sneha is. She doesn't need an introduction. She is the AMOGS chairperson for Medical Disorders Committee. She also was the chairperson for Breast Committee in FOXI in 2019 to 21. And she's a governing council member of ICOG 21-22. And she's recipient of National Award for FOXI for her outstanding work in rural.
Thank you so much, Dr. Niharika.
Yeah. So I think she is going to do a wonderful job as a moderator. I had the privilege to be a panelist under her in the recent Yuva FOXI South Zone at Calicut. I welcome you, ma'am.
Thank you.
May I now have Dr. V. Sitaramraju sir's CV, please. So he is the expert opinion. He's the expert for our panel today. He is the Vice President of OGSV. He is the Director of Sri Krishna Health Center, and he's done his senior residency in JIPMA, and he's been a private practitioner since 1990, quite renowned in the city of Visakhapatnam. Welcome, sir. May I now request Bhavna to project the panelists' CVs, please? Yeah. So we have 8 panelists from the 3 societies of Visakhapatnam, Warangal, and Khammam. So we have Dr. Surekha. She's a consultant OB-GYN from Khammam, and she's a fellow in fetal medicine also. Next. Dr. Rehana Begum is a senior obstetrician from Khammam. She's also the present OB-GYN Society Secretary and ex-secretary IMA at Khammam. Next. Dr. Rajshri is a professor at Gayatri Vidya Parishad Institute of Healthcare and Medical Technology, Visakhapatnam. And she's also a PG trainer and a resource faculty and medical education unit. And she's presented various papers in national conferences. Next. Dr. Sri Vidya is a professor at NRI IMS Visakhapatnam. She was also the former in-charge HOD at the same college, and she's presently our Joint Secretary OGSV. Next, Dr. Jyotsna is, she's an MRCOG. She's completed recently in 2023, and she's a fellow in obstetric medicine in Lakshmi Narsimha Hospital 2022. Dr. Sirisha Mantena is an assistant professor in the Department of OB-GYN at Kakatiya Medical College, Hanamkonda, and she's the General Secretary for Warangal Obstetrics and Gynecological Society. Dr. Rajni is an assistant professor, Mahatma Gandhi Memorial Hospital, Warangal, and she's done her master's in reproductive medicine from UK. I welcome all of you to the panel. And Dr. Fani Madhavi, she is the assistant professor at King George Hospital, Visakhapatnam, and she is also a life member of IMA. I welcome all of you. Dr. Sneha, please take over.
Yeah, thank you so much. Bhavna, can you please stop share? Yeah, thank you so much, Niharika, for that wonderful and generous introduction, I would say. Thank you so much for your help in coordinating this program. So I hope my slides are visible. Are they?
Yes, ma'am. Yes, ma'am.
And I'm audible as well.
Yes,
so
yes.
I think a lot has been heard about the quite theoretical topics and in lots of details as far as the hemoglobinopathies and thrombophilia is concerned. But today, what panel discussion we are going to have, it will be a case-based panel discussion. And I hope it should be practical, should be useful for all of you in the day-to-day practice. So I welcome all my panelists, Dr. Surekha, Dr. Rehana Begum, Dr. Rajshri, Dr. Nemani, Dr. Josna, Dr. Shirisha, Dr. Mantina, Dr. Rajni Pillai, and Dr. Pani Madhavi. And I welcome the panel expert, Dr. V. Sitaramaraju. I hope all of them are here. And please put on your videos if I can see you, all of you rather. So friends, as we have been all the time talking about anemia being the one of the three major causes of maternal mortality, and that is the direct preventable cause of maternal mortality. And that's why everybody is talking, whether it is WHO, UNICEF, Government of India, Minister of Family and Minister of Health and Family Welfare, and of course FOXI and ICOJ. Everybody is talking about Anemia Mukt Bharat. So when it comes to pregnancy, we have been talking about the pregnancy, how it is complicated by anemia and how anemia gets worsened by pregnancy during pregnancy. So should we screen all women for anemia during pregnancy, Dr. Surekha? And what should be the best time for screening for anemia to avoid the complications?
Yeah, good evening, everybody. Thank you, ma'am, for having me here.
Yeah.
Regarding the question, should we screen all women for anemia during pregnancy? My answer would be an emphatic yes. It is very obvious because anemia is a disease which fulfills all the criteria for introducing a screening test. The very reason being that anemia as the disease burden is very high, and it has a significant negative impact on the health of the women. In our country especially, there is increased maternal morbidity and mortality as well as neonatal morbidity and mortality. So because of this, and also because a very simple test such as estimation of the hemoglobin is enough to identify the disorder, and also because the early detection of the disease helps to introduce treatments which will help in reducing the complications and burden of the disease. So therefore, without a doubt, it is important to screen all women for anemia during the pregnancy period.
Correct. So what is the best time to screen? That's what the next question is.
The time to screen for anemia in an ideal scenario would be in the preconceptional phase. Because that is the time we can advise the woman, correct the anemia, introduce folic acid to prevent neural tube defects, etc. But we do not always face an ideal situation. So as early as possible, at the earliest booking visit is the best time to screen the woman.
Yeah, very rightly said, Dr. Surekha. Yes, screening anemia is very, very fruitful. And as you rightly said, yes, definitely simple, easily accessible and available test of hemoglobin estimation. And definitely, if it is screen positive, you have a treatment which is very, very effective. And because the anemia has an effect on pregnancy and pregnancy itself worsens the anemia, definitely detecting it at the earliest, what you rightly said, preconception, I have quoted here even premarital and maybe during her adolescence where she starts her periods and maybe the cause being menorrhagia, puberty menorrhagia and all these things. So American College of Obstetrician and Gynecologist also says in a statement that yes, all pregnant women should be screened for anemia and treated if necessary. But anemia being so rampant to the tune of 25 to over 50%, we have definite guidelines as FOXI, Government of India, Ministry of Health and Family Welfare, that the woman should be screened at the very first point of antenatal contact, that is first antenatal visit, and it has to be repeated time to time, maybe at 16 to 20 weeks, 24 to 28 weeks, and 34 to 36 weeks. So ideally screening should start much earlier. So what would be the investigations to screen as you want to suggest? Whether it should be only hemoglobin or it should be complete blood count?
Even normally in every pregnancy, it would be the red blood cell count, the complete count, and a peripheral smear along with the hemoglobin.
Very true. Exactly what I wanted the answer. There's complete blood count along with peripheral smear. So complete blood count gives you an information on the hemoglobin, hematocrits, and reticulocyte count. It gives you an indication for the various cell indices where you come to the diagnosis almost about the etiology, whether it's a microcytic hypochromic or that is whether it is macrocytic. And of course, when you have iron deficiency or microcytic hypochromic anemia, you have to find out whether it is really so that it is the iron deficiency, or it is just manifesting as iron deficiency, but it is in fact in iron overload. That also happens in hemoglobinopathies. So other cell counts like WBCs, which gives you an indication of infection, platelet count, cellular morphology, and all other very simple investigation, but lots and lots of information. The peripheral blood smear, which gives you an indication about the fragmented RBCs, maybe the hemoglobinopathy with hemolytic anemia also can be diagnosed on this simple investigation. So I think we can go to the next panelist. Can we have, whether it's a manifestation of anemia as direct clinically evident anemia, or you have certain phases where you can intervene and manage it at that level? We can have Dr. Rehana Begum for this.
Yes, ma'am.
Yes. Can you please let us know whether there are any phases of the iron deficiency and how it manifests and how you can diagnose?
First of all, good evening, ma'am, for making me.
Good evening. Yes, please.
There are 3 stages of iron deficiency, ma'am. 3 stages. When by that blood test like serum ferritin. Serum ferritin is the very important test so that we can know whether it is iron deficiency anemia. And by looking at the peripheral smear, we'll know the anisocytosis, poikilocytosis, microcytic hypochromia or other cells, and also hemoglobin electrophoresis to know the type of anemia. And if it is a deficiency.
So, yeah, Dr. Rehana, I just wanted to know from you whether you have clinically evident anemia as at diagnosis, or you can diagnose it much before the actual evident clinical anemia. So whether you can have various stages of, depletion of the iron stores, and then of course the other things.
Yes, serum iron levels, serum ferritin levels, ma'am, and also serum protein levels to know whether it is associated with hypoproteinemia.
Yeah.
And serum bilirubin in some of the hemolytic anemias, ma'am. Serum bilirubin also.
Okay. So you have basically 3 phases where you have the, initially the iron stores are depleted. And the first indication is the low levels of the serum ferritin. So it takes, weeks together to manifest clinically. So if you just have a patient whose serum ferritin levels are lower, you can suspect that this patient may be in negative iron balance. That means the iron stores are depleted. Then, of course, when you do the total serum iron level, iron binding capacity, and the percentage saturation, that is the complete iron profile, then you can have the second phase where you can also diagnose anemia. And then comes the third phase where actually the patient is symptomatic, and then you label it as mild, moderate, and severe anemia. Correct. So I think we go ahead with this discussion and just ask what are the effects of anemia on pregnancy and pregnancy on anemia. We can go to Dr. Rajeshri.
Good evening, everyone. Thank
Yeah,
you.
Professor Rajeshri, we would like to hear from you the effect on either side. Yes.
Good evening, everyone. Am
Good
I
evening.
audible?
Yes,
Thank
yes.
you, madam, for making me a part of this team. Yeah, as we know that 1/3 world's population, the cause for maternal mortality is anemia. So anemia is responsible for 20% of direct and 20% of indirect maternal deaths. So there are maternal effects and fetal effects both. So in maternal effects, can be anemia, infections, then asymptomatic bacteriuria, urinary tract infection, preterm labor, premature rupture of membranes, preeclampsia, which is one of the most this one of maternal mortality. Then increase rates of when the patient can go for congestive cardiac failure during the various phases of pregnancy, during delivery, and after postpartum.
Yes.
So
madam, I would just interrupt you here and I ask you how does the pregnancy affect the pre-existing anemia, whether it worsens, and if yes, how?
Definitely it worsens because the pregnancy itself, there is a physiological anemia. So already if the anemia is there, it is already the added burden on the weakened heart, because there is an increase in the plasma volume by 50%, and the red cell mass increases by only 20%, 20 to 25%. So there is a physiological anemia.
Yes,
there is
hemodilution.
increased and there is hemodilution is there. There is increased demand by the growing fetus and the placenta, which is around 200 to 300. Then there is increased volume. So 500 on a total, there is increased iron requirement about 1000 milligram. And only because of the 9-month saving of iron due to amenorrhea is only 300. So at least there is 900 milligram of deficiency, iron deficiency is there. So definitely.
Very rightly said. I just want to add few points. In addition to this increased demand and the, growing fetus and placenta and all these things, you have a pregnancy being a hyperdynamic state. You definitely have the increased blood volume, but at the same time, the intake is less because the appetite is less and maybe the nausea, vomiting of pregnancy. Also, we are worried about the postpartum blood loss and of course, lactation, as you all know, that breastfeeding in fact needs lots and lots of iron. So that is how, and how does the pregnancy, how does anemia affects pregnancy? That's what you have already discussed about it. So we can just have this chart, whatever you have said on the maternal aspect, the increased risk of infections, what you have enumerated already, the chance of preeclampsia, which is quite high, of course, the intercurrent infection, abruptioplacenty or antepartum hemorrhage, and the chance for operative intervention. And intrapartum, you can have even the labor dysfunctions, the prolonged labor, and the following postpartum hemorrhage as well. Fetal distress and abruptioplacenty, as we have already said, that it can increase the operative intervention. And for the fetus, if you can just talk about, madam.
Fetus, there is a chances of fetal growth restriction. There is a premature release of the preterm prematurity. There can be chances of intrauterine death because if there is a cerebral and fetal anemia. So hemolytic disease of newborn also can be there.
Yes, and the associated nutrition deficiency anemia can have congenital malformation as well. So very rightly said. Yes, in addition to this, you can have a long-term effect on the, the cognitive behavioral effect on the baby and the increased risk of schizophrenia as well. Yes. So we go back to Dr. Rehana Begum. We have this patient, gravida 3 para 2 with 3 months amenorrhea, and she complains of weakness, fatigability, breathlessness. There's no complaint of pain or bleeding. When you examine, her vitals are stable. Per abdomen is soft and non-tender. Her investigations, when you do, you find hemoglobin is 5 gram% only. What other investigations you would like to do for this patient, and how would you manage this patient, Dr. Rehana?
She is 6 months pregnant, ma'am, and she's having breathlessness, and her HB is 5 grams. She comes under severe anemia category. So she needs to be admitted, and oxygen should be given. And now investigation, first we should know the type of anemia. So we do serum iron levels, serum ferritin levels, and we also go for other blood hematological indices like MCV, packed cell volume, and the total RBC count, and HB electrophoresis also, ma'am, to know the types of anemia. Serum bilirubin.
And stool and urine examination as well.
No,
Yes.
Okay, very rightly said about the investigation. What management? How do you want to manage this patient?
Ma'am, packed cell transfusion, because her HB is 5 grams only. And packet transfusion will be given, and after some.
So I ask you a direct question, whether you want to give injectable iron or you want to give blood transfusion, and how do you explain that?
No parenteral iron, ma'am, because she's already having breathlessness. And first of all, let me give her packet cell transfusion and let her hemoglobin rise to around 8 grams. Like that, we'll shift it to parenteral iron therapy.
Can I add, madam?
Yes, please.
Because she is a case of severe anemia, we don't know what type of anemia. If there is a hemoglobinopathy, we cannot give the injector. The first thing is required is blood transfusion.
Correct.
So whatever is
that is what we have been saying. It's a severe anemia. The patient is symptomatic. So first and foremost, you go for blood transfusion. And simultaneously you investigate her what kind of anemia it is. Okay. Now, when you do the investigation, you find that it is a iron deficiency anemia. How would you go ahead? Once you give her blood transfusion, because you have to maintain the hemoglobin, this blood will not be there for the complete duration of pregnancy, right?
Yes, ma'am. After giving 2 or 3 units of blood transfusions, we check hemoglobin level. And if it rises to 7.5 to 8 grams, then we'll switch off parenteral iron therapy.
Okay. What else? The iron-rich diet, everything together. It should be. She should consume the iron-rich diet, good quality diet, having all multivitamins, iron, folic acid, vitamin B12, everything, proteins as well. Suppose you want to give injectable iron for this patient, which iron you will give, prefer, and how much?
Iron sucrose injection we preferring, ma'am. And we'll calculate the deficit, total iron deficit.
How?
By the 2.4 into weight of the body in kilos. Hemoglobin, total hemoglobin 14 minus hemoglobin deficit plus 1000 milligrams of iron storage.
Correct. So that is how. Can you give ferricarboxymaltose, FCM? Yes. There has been a consensus saying that yes, even foxyticipar this. Previously there was a concern that maybe during first trimester you cannot give this injectable iron, but now it has been proven beyond doubt that if she doesn't have idiosyncratic or hypersensitivity reactions and she has iron deficiency, we can definitely give injectable iron during first trimester even. So thank you so much, Dr. Rehana. Now we move on to, I think, Dr. Rajeshri, this is a case for you. We have this primary gravida with 5 months pregnancy. She's absolutely asymptomatic. And she comes to you for routine checkup. Her appetite and intake are good. And there are no complaints of digestion. And hemoglobin is 8 g/%. Her blood group is AB negative. Sickling is negative. Peripheral smear suggestive of microcytic hypochromic anemia. What other investigations you want to do, and how do you manage this patient? 5 months, 8 grams.
There are having 2 problems. One is her hemoglobin is 8 grams. So she comes in a category of moderate anemia. Secondly, she is having vomiting, loose motions. Her complaints.
She has no complaints of.
Okay. Her blood group is AB negative.
So you want to prepare her and keep it ready as 11, 12, right?
Yes, she is having, because her blood group is negative, and already already we have discussed the investigations, like, or the red blood cell indices, the cause for anemia, like urine routine microscopy, and stool for ova cyst, occult blood.
Yeah, only one specific investigation I have asked for, because she's having 8 gram%. So what type of anemia? It's an iron deficiency on peripheral smear.
So HB electrophoresis.
One. And the iron profile, complete iron profile, yes. So peripheral blood smear can show you microcytic hypochromic anemia, but when you actually do the iron profile, there may be iron overload. Yes. So hemoglobin electrophoresis and serum ferritin levels, or maybe complete iron profile. This is what we have already discussed, that it can have, effect on both mother and fetus. So now she has got moderate anemia, very correctly said, and type of anemia is iron deficiency. So you do hemoglobin electrophoresis and serum iron profile because she is Rh negative, and otherwise also you want to keep her ready because you have so many problems, including FGR and all this effect on the mother as well as fetus both. So apart from routine antenatal profile, obstetric ultrasound, we have to, do it regularly. We have to, promote her good intake of the nutritious food, and we have to, if at all she's comfortable, 8 grams. So if she can consume and compliant and she can tolerate, we can give her oral iron, and of course we can wait for the results because it is 5 months only. We still have some time. So maybe for 1 or 2 months we can wait and look for the result, as you have said, the oral iron and the nutritious diet. If it is not well tolerated, or if she's not compliant, then we can go for injectable iron even at this point of time. So very well discussed, Professor Rajeshri. And now we go to Dr. Nemani Srividya. So Dr. Srividya, we have this case for you. Is she there?
Yes, ma'am. Good evening, everyone.
Hello, Srividya. So we have primigravida, 4 months pregnancy with, she's complaining of severe weakness, giddiness, nausea, vomiting right from early pregnancy. So when you examine her, you find that she's anemic. I haven't given you the levels of hemoglobin, but she's anemic. What investigations you want to do for this, and how do you manage this patient? What kind of anemia?
Actually, this is a case of hyperemesis gravidarum. As you know, it is like she is having nausea, vomiting, and severe weakness since her early pregnancy. So you need to first look for this causes for hyperemesis. Maybe that is the reason why she is having this anemia, which may be nutritional anemia most probably, because of iron deficiency and then B12 and folate deficiency also. So we have to look for investigations, like first regarding hyperemesis, we need to do her thyroid profile to rule out thyrotoxicosis, and then
we talk about the anemia first. How much?
CTC, LFT, RFT, other systemic, to rule out other systemic dysfunction, and then we need to go for CBC, and then her blood group, and then iron studies if necessary, after doing her peripheral smear. So in peripheral smear, you can look for like sickle cell sickling and all. So because of poor intake, like nutritional anemia, we can go for injectable iron rather than oral iron, because oral iron further increases her gastritis and nausea, vomiting. So injectable iron is the best treatment for her.
Yeah. So you will find out what is the type and severity of anemia, and meanwhile you will manage her vomiting, hyperemesis. Okay, so for hyperemesis, you will also investigate her for the cause of hyperemesis. Okay, so what can be the obstetric causes for hyperemesis you are suspecting at this time?
Maybe she is having a multiple pregnancy or a molar pregnancy, we don't know. Unless you do an ultrasound, we can't come to a conclusion what cause.
So we advise obstetric ultrasound, correct. Okay, what else? Any experience with when the patient has GDM or diabetes, whether she has hyperemesis.
Diabetic ketoacidosis, diabetic ketoacidosis could be the reason. We need to rule out other systemic disorders like liver function test, renal function test, and her random blood sugar to be tested.
More important to rule out in such patients.
Ma'am?
CKD, chronic kidney disease.
CKD, yes, ma'am. Kidney diseases, liver disorders, yes, ma'am.
Yeah. So how would you manage her specific and non-specific management?
Specific management, we need to correct her hyperemesis with antiemetics, and we have to admit her, and then you correct dehydration, and depending on these electrolytes, you need to correct the electrolytes disturbances also. And then if patient is not coming up out of this hyperemesis, we can advise oral iron later. But if depending on the grade of anemia, degree of anemia, if she is having a moderate to severe anemia, we need to go for IV iron, even though she is in second trimester, like 4th month, along with MVI, multiple multivitamin injection.
Correct. That is what the message is. It's not only iron, but the proteins, vitamin B12 and folic acid. So everything has to be supplemented. Then only such kinds of anemia will respond properly. Correct. So dietary advice, once she is now, you have controlled her
patient should be
vomiting.
educated. Patient should be educated for dietary advice. That is more important when there is nausea and vomiting with iron supplementation. And also that she should be advised to take this iron supplement. She should not to take with tea, coffee, tannins or phytates. Okay, she has to take this oral supplement.
One simple question I want to ask you, while making this transition from IV fluids and then oral, that you know,
Yes, ma'am. We need to educate her regarding this nutritional causes for decreased iron absorption.
What is that?
So you can educate the patient regarding she can take with vitamin C so that will increase the absorption. If this nausea has subsided, she can take with oral. If nausea has not subsided, she can take this oral supplementation along with food, although it will decrease the absorption, but it will help somehow to increase her iron stores.
My simple question is, hello? My simple question is, when she has been given injectable iron by you, do you really want her to bombard with oral iron?
No, ma'am, not when she's taking injectable iron.
So already she has
after
hyperemesis.
3 to 4 weeks.
Yeah.
After 3 to 4 weeks, you can check the hemoglobin level and then go for oral iron if necessary.
Yeah, exactly. So that brings us to the end of this case discussion, and we go to Dr. Josna now. I'm purposefully taking it very simple, practical discussion, because theoretically everybody is well aware. When the patient comes to us, how we have to deal with her, that is what we have to discuss here. So Dr. Josna, you have this primigravida with 3 months amenorrhea. She comes to you with severe body ache, swelling of lower extremities, breathlessness, and high colored urine. What is your clinical diagnosis, and what investigations would you like to do? That already I have mentioned here, but what is your diagnosis from the history?
Hello, ma'am. Good evening.
Yes,
thank you for the opportunity.
Yes.
So she like it is positive for sickling, and her hemoglobin is 5 grams, and with the history of painful lower extremities, it seems to be acute painful crisis with sickle cell disease. So we would she requires a multidisciplinary approach where she will be admitted and investigated.
Yes.
For the complete blood picture and liver function test, kidney function test also. And then we would also want to know what is the triggering factor in her.
Right.
Why did
so
she land up
what
in
are
having
the
an
things
acute painful crisis?
Suppose your patient now, she has 3 months pregnancy and she has edema, breathlessness, and high colored urine. That means she has anemia and she has hyperbilirubinemia. So it's a hemolytic anemia. That's what you can guess clinically. And you
Yes,
have
ma'am.
this investigation, so you have to come to a diagnosis that yes, she has got sickle cell disease and now she is into crisis. What kind of crisis you feel that she has, and what are the types of crisis? In other words, I would just to discuss.
This patient is having acute painful crisis, and the other crisis that can happen in the sickle cell is like acute chest acute chest syndrome, where she can have breathing difficulty, saturations below 90, and
So
that will also
yeah.
require.
Yeah.
Yes, ma'am.
Mainly, the crisis which present clinically, which are very dangerous, are three types. One is the one is hemolytic crisis, and secondly hemolytic crisis, and secondly you have the vaso-occlusive crisis, where all the organs, they undergo ischemia, including all the splanchnic ischemia that is called as. So she gets severe abdominal pain. And third is where you get generalized swelling of all the joints. So maybe even the bleeding inside the joint
Bone
cavity.
crisis.
Yes. So that is the bone crisis. So these are the clinically significant crises. So what are the factors which trigger the crisis? In other words, I would ask you.
Yeah, the triggering factors
And what,
could be.
I mean, that's the reason how you can convince and counsel your patient that these are the things you should avoid. Yeah.
Yeah, so exposure to cold and excessive vomitings, dehydration, and infections, excessive exercise, stress. These are the triggering factors. So we would advise them not to expose themselves to the cold. Identify if she feels that she's having a little amount of pain. Ask her to take it easy with the physical exercise, and adequate hydration is important. And whenever she has nausea, she comes to the nausea vomiting.
Hydration, I did understand.
She should come to the hospital.
Yeah. Hydration, I did understand that yes, you should not allow the blood to clot, and the sequestration should not happen. So hemoconcentration and sequestration should be avoided to avoid the hemolytic crisis. I didn't understand about the cold. What message you want to give it to the patient? What she has to avoid? What does cold lead to in this patient? It leads to vasoconstriction. And so vaso-occlusive crisis we want to avoid. And thirdly, she should avoid crowded places, closed spaces, and she should avoid high altitude where the oxygen saturation is poor. Yes. So hypoxia is a trigger, mainly. Hypoxia is a trigger. Correct. Okay. So how would you go ahead with the management? That's what.
Okay, for this patient, she needs admission and to check the triggering factor, and also she requires blood. She requires pain management. Ideally, it would be with paracetamol or any of the codeine derivatives. Especially, it is better to avoid the NSAIDs and pethidine. And she requires oxygen and thromboprophylaxis, antibiotics.
Yes,
so it is
that is what we want to say.
Approach.
So low molecular weight heparin has a place here in cases of sickle cell disease. Yes. So that's a very good answer, in fact, and very well discussed. Yeah.
Ma'am,
so yeah, please.
Ma'am, I wanted to add a few points.
Yeah, please.
Points regarding the hemoglobinopathies. So what I have seen in the clinical practice is in beta thalassemia traits women, even with the hemoglobin of 10 and 11, they do not usually have anemia. But when we do the HB electrophoresis, we see them having the beta thalassemia trait. So that is one important thing where universal screening of the woman is important, especially in the in our region. One more important thing is when the woman is severely anemic, like if she has hemoglobin of 5 or 6, or anything below 7, is it a better idea idea to do the hemoglobin electrophoresis at that point of time, because it may change the report. Does it have any effect on the?
If you had seen the previous discussion, we are always talking about that we must know the cause of anemia along with the cause and severity of the anemia. So whatever may be the severity of the anemia, we have to know the cause, whether it is nutritional deficiency, whether it is inadequate production, whether it is the destruction, whether it is the blood loss. So all these points have to be considered. And whenever for all the cases, we have been saying that this is a protocol of investigations we need to follow, and we must investigate to know the cause of the disease. It's not a one-time treatment and then just leave it as it is. So it has to be followed up, and that is why we are talking about the even the continuation of the oral or iron, and of course the diet rich in nutritional values, so iron, vitamins, and everything. So we have to investigate, and that's what the message is coming. Though it is not an official recommendation that we should go for the hemoglobin electrophoresis as a routine, as a practicing obstetrician, all of us are going for this. So it is advisable that we go for the hemoglobin electrophoresis as a routine.
And I wanted to reiterate one more point where if we find a woman with higher hemoglobin, so we anyways supplement her with folic acid. So even adding vitamin B12, especially when the woman is severely anemic, because the peripheral smear also masks the vitamin B12 deficiency. So adding the B12 would be a better idea.
Okay, thank you, Dr. Josna, for your
Thank you,
inputs.
ma'am.
So Dr. Shirisha, we have this patient for you, second gravida, paraben, 9 months pregnancy. She came to you in labor with a report of hemoglobin 3 g%. She is in active labor already. How would you manage her?
Good evening, ma'am. Thank you for the opportunity.
Thank
you so much.
Pleasure.
So this is the patient, that is the real challenge for the obstetrician, madam. They have to take care of the mother, the child, the in utero fetus, and at the same time without any morbidity and mortality. So this is a tricky time to be meticulously managed, madam. So this patient has come with 3 grams of hemoglobin, the very severe anemia. We doesn't know her condition, compensated, decompensated, or whether she's in cardiac failure, which is to be evaluated as soon as possible. So as the patient has come in active labor, she has to deliver. We can't stop that. And she has to deliver mostly by vaginal route only, not to go for section. Only for obstetric indication, she should be taken with the blood in hand, madam. So as soon as the patient comes, the patient should be in propped up position. She has to be given oxygen, supplementation, and IV access cannula is to be given. And definitely all the blood investigations have been already taken and found the HB to be 3 grams, madam. So the blood should be in hand. Packed cells are to be readily available as soon as possible. We have to take, the main thing is not to overload her. Not overload. It is better to be in negative fluid balance.
So should we start IV fluids? That is what the first query is.
No, madam.
Whether you just put in IV cannula, but you get the blood ready, or and start blood transfusion as early as possible.
Even the blood transfusion is better to start after delivery, madam, not before delivery. Only when the situation demands, we have to go for blood transfusion before delivery. So even the IV fluids with Syncto also, that should be judiciously. That should be deciding factor for the condition. And the labor should not be too much progressed. The mother should not get exhausted. The second stage of labor should be managed properly. The delivery should be cut short, either with forceps or ventouse. And probably if it is chronic anemia, there may be IUGR. Even if there is no IUGR also, we try to avoid the episiotomy, not to bleed her. So if at all episiotomy given or any tears done, early repair of the tear should be done. And third stage of management of labor should be really good. And we should not give ergometrin, madam. Injection ergometrin should be avoided. Better we can go for tablet.
Concentrated Oxytocin?
Yeah, madam.
Concentrated oxytocin infusion, or maybe intramuscular oxytocin.
Intramuscular maybe.
Yeah. Okay.
And followed by blood transfusions at any cost. That is the life-saving thing for this patient.
Yeah. Any role for Lasix, furosemide?
Yes, definitely, madam. Definitely. Blood transfusion along with the furosemide or Lasix should be.
Yes. Yes. So very well discussed. In fact, here we should not worry about what is the cause and what investigations to be done. Right now, she is in active labor and severe anemia. So we have to manage her as a dire emergency. And we have to get rid of the labor process also. We cut short the labor process, augment if at all possible, needed, and go for the active management of third stage of labor, as you have very correctly said. But of course, restrict the use of ergometrin. Here may be the place for carbetocin, if at all your experience is good. But yes, oxytocin, the age-old drug, and concentrated oxytocin infusion definitely helps. But you have to keep the patient propped up, give oxygenation, and maybe even the furosemide, as we have talked about, and start blood transfusion, that is packed cell transfusion, as soon as possible, but very slowly.
During the process of all this going on, we should definitely anticipate the postpartum hemorrhage, madam.
Yes,
Give the patient room for PPH.
exactly. So for this, I invite Dr. Rajni here. What are the components of active management of third stage of labor, Dr. Rajni? And in this case, how would you go for it?
Madam, she had some technical issue.
Okay, she did join. Okay, so I think you can continue with this.
So definitely active management of third stage labor. This is the life.
For the second stage, I think before we go to third stage, for the second stage, did you say something? You need to cut short this area.
Yes, actually, during the process of labor, active management already the patient is already in active stage. So beyond 4 centimeters to 10 centimeters, there is 6 centimeters. If she is gravida 2, multipara, she can even deliver before 6 hours of time, madam. So,
correct. So no unnecessary delay, no unnecessary prolongation of labor. That is one. Cut short the second stage of labor. Yes.
Cut short the second stage of labor. Better to augment the labor, and forceps or ventouse delivery, followed by the concentrated syntocin in 1 RL, and that should be slowly given. Concentrated syntocin IV, and we can go for misoprostol tablets per rectal also, madam. That is also judicious.
Yes, and 600 to 800 milligrams.
Yes, madam, 800 per rectal. And if the patient doesn't land up in PPH, that is fine and good. If the patient she's more prone for PPH, so the PPH kit should be ready. Either uterine tamponade should be done, or first medical management followed by interventional management, madam.
Okay.
Immediately after delivery of the baby, we have to go for that placenta. Delivery of the placenta, not to active management.
Yeah.
The uterine massage, we can go for
controlled contraction.
Controlled contraction. And we have to deliver the placenta, then followed by blood transfusion.
One point I have mentioned here, you tell me whether you agree. It's a delayed cord clamping.
No, madam.
Tell me why, and I tell you why.
So
it's a delayed, come.
Delayed cord clamping in normal pregnancies, normal mothers, it is better. We can go, but here actually that
the baby is not depressed. Baby is not depressed. Let me tell you. Let me justify why I have kept it here. Because it says even the Foxy and IOP, both of them have said that this is baby's own blood. And it's called as auto transfusion. So this is baby's right. That is what the IAP, Indian Association of Pediatrics, is saying now. And it's always good to do delayed cord clamping for every baby, unless the baby is in distress. Okay. And now why so? Because when you're doing delayed cord clamping, you're getting additional blood, and the iron stores and iron levels of the baby which we are worried about as a long-term complication. I had just discussed that there can be even the cognitive behavioral dysfunction and long-term or severe anemia in these babies also. And that's a very reason we have to go for delayed cord clamping. And of course, if the patient is bleeding, she's landing up into postpartum hemorrhage, we will not do it. That is a contraindication. Okay. So we go ahead with this. I think I invite Dr. Fani Madhavi.
Madam, can I
for
add something here?
Yeah, please.
So to go for prophylactic antibiotics, here
Yeah,
there is a
yes.
prophylactic antibiotics. And second thing, better to have a multidisciplinary approach in this case, and better to have a tertiary care center. This case to be managed.
Correct, correct. 3 grams per cent. Definitely, we would at least, we have already said a blood bank, and of course the physician or intensivist, definitely. So a good suggestion and good input from your side. So I would invite Dr. Madhavi here, Fani Madhavi. What are the guidelines, Government of India guidelines for iron deficiency? We are in the era of this now. It's a need of the hour to make India anemia free or anemia mukt Bharat. So what are the steps Government of India is taking for this? So if you can just talk about this.
Good evening, madam. Actually, WHO guides us to provide 60 milligrams of elemental iron per every pregnant woman from 4th month onwards till postpartum 3 months.
Yeah.
But our Government of India, because 50% of our women are anemic, so
yes, right. Hello. Yes, Dr. Madhavi. Hello.
along with increased dose of folic acid, actually it has suggested 500 milligrams from 14 weeks onwards. Subcenter. Hello, am I audible, ma'am?
Yes, yes. Now you are audible.
Sorry, ma'am.
Yeah.
We have increased our folic acid dose also. It is increased from 400 to 500 milligrams of folic acid and distributed for 100 days from starting from 14 weeks. And it will be distributed through sub-centers with ASHA workers to home distribution.
Yeah.
And they'll go and cross-check whether she consumed it or not.
Yes. Hello. Can you all hear me?
Yes, ma'am. Yes, ma'am.
Yes. So it's Dr. Madhavi. I think she has an internet issue. So can we have Madam Rajeshri? You can take up this.
Yes, madam. So as Fani already said, it is the Ministry of Health just said for 100 milligram of elemental iron and 500 milligram of folic acid starting from 14 weeks. So it has to be at least for 100 days.
Correct.
But to be continued in postpartum period also. And she has already mentioned that the ASHA workers, they will be distributed, it has been. And 12 by 12. So our motto is at the 12 years of age, the hemoglobin should be 12. So the adolescent population is also targeted to have a hemoglobin one. And
correct. So as all of you have said it right, but only one thing I want to add, the Village Health and Nutrition Day, the nutrition counseling as well. In addition to distribution of this iron and folic acid tablet, it should be the nutrition counseling as well through the village health workers as well as, the ASHA. They should also provide these counseling sessions, and they monitor the whether these women, they are actually taking the tablets or not. I think that should be so according to WHO, the oral iron supplementation either alone or in combination with folic acid, it has to be started from early pregnancy and should be continued to 6 to 12 weeks postpartum. That is what is the recommendation. In cases in which a woman is diagnosed with anemia, she should be treated in accordance with the country's policy or the WHO's recommendation. And we are talking that WHO's, it is Now it is 120 milligram of elemental iron plus 400 microgram of folic acid till the hemoglobin concentration returns to normal. So what is the recommendation for this postpartum anemia? This definition is hemoglobin less than 10 gram% in the postpartum period. I think again it is getting revised to 11 gram% at the postpartum period itself. I was a part of this revised policy making and the advocacy meeting also for this postpartum anemia. So there again it is getting revised that it should be done on the 3rd postpartum day and again at 6 weeks postpartum, and it should be maintained to 11 gram% even during postpartum period. Anything less than 11 gram% should be taken as anemia, and postpartum injectable iron should be given at least as 1 shot. That is what the recommendation is. This is the recommendation for the treatment of postpartum anemia for the British Committee. This is according to the British Committee for Standards in Hematology 2019. You have various guidelines, but for us, I think the WHO and Government of India guidelines are the ones which we are following. And 3 gram of elemental iron, 500 microgram of folic acid. It has to be started from 14 weeks of pregnancy and has to be continued in the postpartum period as well. And the hemoglobin of every woman should be above 11 gram%. So generally the postpartum represents a dire need for supplementation in such anemic patients. We have lots and lots of problems, including puerperal sepsis, puerperal psychosis, and of course the lactation failure or inadequacy. So pericarboxymaltose, either dextran-free iron preparation that allows the rapid administration of high dose of iron, even up to 1000 milligram we can give it. And that's a very reason it has been found to be very safe and effective, minimum adverse effects, and even the critical reactions have been observed. So do we have Dr. Pani back to us once again? What interventions are recommended for the Anemia Mukt Bharat? So do we have Dr. Pani? Or anybody else can take up. Dr. Srividya, do you want to take up these points? What are the interventions for Anemia Mukt Bharat?
Actually, Anemia Mukt Bharat is concentrating on all the age groups to prevent anemia.
Yeah.
With iron supplementation in starting from the 1 to 5 year age group, and then 10 to 15 year adolescent supplementation of iron. And then pre-pregnancy, reproductive age group females supplementing iron, and this JSSY, JSSK, which are promoting this nutritional advice to the patients.
Yeah.
And then it is focusing on all the age groups so that it will prevent anemia in the pregnant women later.
Correct. So we have this prophylactic iron and folic acid supplementation we have talked about, and we have this deworming program as well. So intensified year-round behavioral change communication campaign, that is solid body, smart mind, including ensuring delayed cord clamping in newborns, what I have just talked about, testing of anemia using digital methods and point of care treatment, mandatory provision of iron and folic acid, and fortified foods in government funded health programs, addressing non-nutritional causes of anemia in endemic pockets, with special focus on malaria, hemoglobinopathies, and fluorosis. So that is all from my side, I think. And if you anybody wants to add anything to this, will be welcome. So I think we have come to the end of the panel discussion. Anybody? Yes, Dr. Shirisha, you can go ahead.
Madam, there is something, vitamin C is very much important for the absorption of the iron.
Yeah, that is, we have to talk when we are asking the patient to take consume the oral preparation. That is, we have not gone into whether it should be consumed before meal or after meal, whether iron and calcium can be taken together. There are various issues to be discussed. So definitely you can share your views. Yes, all of us can listen to.
Yeah, ma'am. This nutritional supplementation is equally important. We are correcting the anemia, and we have to equally educate the mother, the pregnant lady, regarding the intake of the iron and iron enhancing foods also. the proper educating her is really important for the to avoid the repeated either blood transfusions or injections, or even we can decrease the oral intake of the iron supplements also.
Yes. So in fact, it is said that the Indian diet is rich in iron, because also we prepare many food preparations in the iron, wares as well. But because of the phytates and phosphates in our food and the tea, of course, tea and coffee, it decreases the absorption because of the myths that our patient feel that, you get hyperacidity consuming the, it's not a myth, but yes, maybe they feel that it's better to take any tablet after meal, and that's the very reason there is reduction in the absorption. As we have been discussing, iron and calcium, they're taking it together because of lack of knowledge, and we are maybe sometimes failing in our duties to make them aware about this. So that's a very reason, in spite of consuming the tablets and in spite of taking iron rich foods, maybe there is a iron deficiency status here. So I think all of us should make an honest efforts to convince and counsel these women regarding their dietary intake and having nutritious diet in all aspects, and of course not to have the iron tablet after food. In fact, have it on with a glass of lemon water, I would say. That is what we have been advising our patient. Definitely, as you rightly said, vitamin C definitely increases the absorption of iron. I think that's all. If Madam Balamba has to make some points.
Madam, I have a small query. Excuse me, madam.
Yes, please.
Yeah, actually, can we give IV parenteral iron to the first trimester pregnancy ladies, ma'am?
Yes, it previously there was a concern, but it has been very much clarified that yes, you can. Yes.
It is given that safety data are not available regarding first trimester administration of this IV iron, parenteral iron, ma'am.
But even Foxy has come up with the GCPR on anemia, saying that yes, madam can make a comment on this.
It's prudent not to give in first trimester, first of all, because if at all there is a malformation, then they will attribute it to your iron. The second thing, if she aborts, again they will attribute it to the iron. So it's always prudent not to give anything in first trimester unless it is really mandatory to give. Okay, so you have to think of medical legal things also, and the patients getting annoyed with us, because we have told them that. See, like we said, all patients, adolescents should be healthy. And then I told you about how only 23% are consuming iron in Anemia Mukt program. We have discussed so much about Anemia Mukt program, but the implementation is very poor and the evaluation is not at all there, whether the hemoglobin is increasing there or not. So our programs, all programs of Government of India in planning is very good. Implementation is not that good. Evaluation is zero. So I think, from Foxy side also we have to do something about it, because all the professional bodies say something about Anemia Mukt Bharat, Anemia Bhagao, Anemia Bachao, whatever, but we are not doing what we ought to do. I think, that is where we are failing. And then, as obstetricians, I think we have to take it up more and more. And when adolescents come to us, we have to tell them to take iron. We have to tell them to take even calcium with vitamin D, because this is when they are going to bank their calcium in their bones. Yes. So these are all things in the nutritional advice, not only to the mothers, but the children, and to avoid junk food. There are so many things which we can do as obstetricians. And if we can do, maybe we will chip in a little bit, and at least, we have a drop in the ocean maybe, but still, we will be doing something to prevent anemia in our pregnant women.
Yes. Thank you so much, madam, for your inputs. In fact, for every talk and every program we have been talking about, at the end of it, the healthy food and healthy lifestyle has its own place. And we as a doctor, I would say, not only even obstetrician, even a family physician or any doctor should talk to our patient as far as the nutritional aspect and healthy living is concerned. So thank you so much, madam, for your inputs. And I seek all of your blessings for my candidature as Foxy Vice President from West Zone for the upcoming elections of 2023. So thank you so much, everyone.
One more thing.
Yeah.
Yeah, the thing is that the woman is anemic in first trimester means definitely there is a pre-existing anemia.
Anemia, right?
Find out that cause. The
Yes.
second thing I wanted to tell you is the transfer of iron to the feet starts in the second trimester. So not too much of hurry in the treatment of anemia in first trimester unless it is very severe. Suppose it's very severe anyway, we are screening for other causes of anemia, and we may have to give transfusion and all. So don't hurry about IV iron. As madam said, that is very relevant. And transfer to the fetus, siphoning starts from the second trimester. And the other thing is we find very large number of term anemias in spite of taking iron and all that. The problem with the practitioners ourselves is once they start prophylactic iron dose in the second trimester, irrespective of hemoglobin level, even if it is especially in periphery, these healthcare workers, they start iron at prophylactic dose, irrespective of iron, their hemoglobin level. If they need therapeutic level, start therapeutic level in the second trimester, not the prophylactic dose. That should be important.
As a matter of fact, now it is said that you need not even give iron every day, because there is only a certain limit of iron which is going to be absorbed. Even if you give 100 milligrams, even if you give 200 milligrams, all of this is not going to be absorbed. Only 15% will be absorbed in a non-pregnant person, but otherwise, in pregnancy, it increases. The absorption increases because the hepcidin levels come down in pregnancy. But that doesn't mean, you have to give therapeutic doses. It doesn't work at all. But at least see to it that they take the prophylactic levels also. But even that they are not taking. That is the problem. So we'll have to see to it that, as I said, in school-going children, we have to start on with all this.
Yes.
That's it.
So all the best, Dr. Sneha.
Yeah,
Thank you so much, Dr. Radha. Thank you so
and
much.
my blessings to you. That's it. Thank you. And
Thank
bye-bye,
you
everybody.
so much, madam.
Bye, everybody.
Yeah, I just thank all of you formally. The chief guest, Dr. Shanta Kumari and Dr. Rajendra Singh Pardesi, and guest of honor, Madam Balamba and Sujata Dalvi, and all my dear esteemed faculties, Dr. Niharika, Dr. Sandhya, the esteemed panelists. I can see here Dr. Josna, Dr. Rehana Begum, Dr. Rajshri, Dr. Shirisha, Dr. Sri Vidya, Dr. Surekha, and of course, Dr. Madhavi. P. Madhavi. So thank you so much once again. And I thank Dr. Niharika and Dr. Lakshmi for the wonderful coordination. And I thank Dr. Aruna Suman as well for taking the initiative for this program. Thank you so much.
Thank you. Good night, everybody.
Good night, everybody.
Good night. Thank you so much. Thank you. Thank you, Niharika.
Thank you.
Best wishes.
Thank you, dear. Thank you so much. Bye-bye.
Good night and all the best, Dr. Sneha.
Thank you.
Thank you.